Guys, let's continue from yesterday. We were talking about blood volume and blood pressure. Let's continue about blood volume. Another podcast with ChatGPT. Are we ready to go, dude?
Absolutely. Blood volume plays a crucial role in regulating blood pressure. When blood volume increases, it raises blood pressure because there's more fluid in the vessels. On the flip side, if blood volume drops, blood pressure can fall too. This relationship is essential in conditions like dehydration or hemorrhage. What's our next focus?
Let's compare aldosterone with ADH in regards to why aldosterone.
All right.
Wait,
Aldosterone and
wait,
ADH
just a
both help
second.
regulate.
Yeah, so why is aldosterone in the adrenal cortex and then ADH is in the pituitary, posterior pituitary?
Great question. Aldosterone is produced in the adrenal cortex because it's part of the renin-angiotensin-aldosterone system, which is crucial for balancing sodium and potassium. The adrenal glands, sitting on top of the kidneys, are strategically placed for this. ADH, or vasopressin, comes from the posterior pituitary because it responds to signals from the hypothalamus about the body's water balance, helping to conserve water by reducing urine output. Each hormone has its own role
Yeah,
and
but I
location.
don't understand. I don't understand. How come um, the renin-angiotensin-aldosterone system is is a sufficient reason for aldosterone to be secreted in the adrenal cortex?
So, the adrenal cortex is a prime spot for aldosterone production because it ties directly into the body's response to changes in blood pressure and electrolyte balance. When blood pressure drops, the kidneys release renin, kicking off the renin-angiotensin-aldosterone cascade. This system is crucial for rapidly adjusting blood volume and pressure, and
Yeah,
having aldosterone.
but I still don't understand why adrenal cortex is better for aldosterone than the, let's say, posterior pituitary.
Got it. The adrenal cortex specializes in producing steroid hormones like aldosterone, which helps regulate electrolytes and blood pressure. It's already equipped with the necessary enzymes and pathways for this. The posterior pituitary, on the other hand, is focused on peptide hormones like ADH, which manages water balance. Each gland is specialized for different tasks, making them efficient in their roles.
Alrighty.
Awesome. Feeling good about that explanation?
Well, to be honest, I have more questions on it, but we've got so much to cover today. Hopefully next week we can cover it again.
No worries. We can always dive deeper next time. What's next on the list for today?
Can we talk about BNP, B-type natriuretic peptide?
Sure. B-type natriuretic peptide, or BNP, is a hormone released by the heart, especially when it's under stress, like in heart failure. It helps reduce blood pressure and volume by promoting sodium excretion and dilating blood vessels. It's a useful marker in diagnosing and managing heart failure.
I don't understand. Tell me more. Tell me more.
Sure thing. When the heart is stretched or stressed, like in heart failure, it releases BNP. This hormone helps the body get rid of excess sodium and water, which reduces the workload on the heart. It also relaxes blood vessels, lowering blood pressure. Doctors measure BNP levels to assess how severe heart failure is and to monitor treatment effectiveness.
So, it's a peptide hormone. What exactly in its structure makes it a peptide hormone?
Exactly. A peptide hormone is made up of amino acids linked together in a chain. BNP is relatively small, composed of about 32 amino acids. This structure allows it to act quickly in the body, binding to specific receptors and triggering responses like sodium excretion and blood vessel dilation.
So it reduces fluid overload during a CHF, heart failure.
Exactly. By promoting sodium and water excretion, BNP helps reduce fluid overload, easing the strain on the heart in congestive heart failure. This lowers blood pressure and reduces symptoms like swelling
So,
and shortness.
it's the opposite of aldosterone.
In a way, while aldosterone promotes sodium retention and increases blood volume, BNP encourages sodium excretion and reduces blood volume.
So it's
They
literally
balance.
the opposite action.
Exactly. They work like two sides of the same coin, keeping your body's fluid and blood pressure balanced.
And where is this produced? Because aldosterone is in the adrenal cortex.
BNP is primarily produced by the heart, especially the ventricles. It's released when the heart muscle is stretched due to increased blood volume or pressure. This makes it a key player in responding to heart stress.
Tell me again.
Sure, so BNP is made in the heart, especially when the ventricles are stretched from too much blood volume or pressure. It's like a signal that the heart needs help managing the load, prompting the body to excrete sodium and water, easing that strain.
Don't understand.
No worries. Think of BNP as the heart's way of saying, hey, there's too much
So
pressure.
wait. It's produced by the heart then?
Exactly. The heart, especially the ventricles, produce BNP when they're under stress.
Okay, and how does it actually act to reduce the fluid overload?
BNP acts by promoting sodium excretion in the kidneys, which pulls water out with it. This reduces blood volume and eases the workload on the heart, helping to lower blood pressure and reduce fluid overload.
Okie dokie. So erythropoietin.
Erythropoietin, or EPO, is a hormone produced mainly by the kidneys. It stimulates the bone marrow to produce red blood cells, which is crucial for oxygen transport in the blood. It's especially important when oxygen levels are low, like at high altitudes or in anemia.
Hmm. And what do we measure? When is it wise to measure EPO?
Measuring EPO levels is useful when investigating unexplained anemia or polycythemia. It helps determine if the body's producing too much or too little EPO, guiding diagnosis and treatment for conditions like chronic kidney disease or bone marrow disorders.
Because if it's producing too much, it means that they're faulty.
Exactly. Too much EPO can indicate a problem like a tumor or a condition causing excessive red blood cell production. On the flip side, low EPO could mean kidney issues or other factors suppressing its production.
Polycythemia vera means you have too many cells.
Exactly. Polycythemia vera is a condition where the body makes too many red blood cells, thickening the blood and increasing the risk of clots. EPO levels are usually low in this condition because the bone marrow is producing cells independently.
But what happens to oxygen binding to hemoglobin in polycythemia vera?
In polycythemia vera, despite having more red blood cells, oxygen binding to hemoglobin remains normal, but the blood becomes thicker, which can slow down circulation and reduce oxygen delivery to tissues. This can lead to symptoms like fatigue or headaches.
Yeah.
It's a tricky balance.
Okay, we've established that the arterial end has higher pressure than the venous end, right?
Exactly. The arterial end of the circulation has higher pressure because it's closer to the heart's pumping action. As blood moves through the capillaries and into the venous end, the pressure drops significantly. This
And
pressure difference
and we've
is
established in previous episode that the hydrostatic pressure is kind of from the gets fluid to go outside, pressure to go outside or something.
That's right. Hydrostatic pressure, especially on the arterial side, pushes fluid out of the capillaries into the surrounding tissues. This helps deliver oxygen, nutrients, and other essentials to cells. On the venous side, the pressure drops, allowing fluids to be reabsorbed.
And then we have a lot of albumin, which makes water come inside to balance the concentration, and that's the oncotic pressure.
Exactly. Albumin creates oncotic pressure, which pulls fluid back into the capillaries from the tissues. This balances the hydrostatic pressure, keeping the right amount of fluid in the blood vessels and preventing swelling.
The oncotic can also be called osmotic.
Yes, oncotic pressure is a type of osmotic pressure, specifically due to proteins like albumin. It's sometimes called colloid osmotic pressure because it's generated by large molecules. Both terms describe the same pulling force that helps keep fluid in the bloodstream.
Hmm.
You got it.
What about the net pressure?
Net pressure is the balance between hydrostatic and oncotic pressures. It determines whether fluid moves in or out of the capillaries. If hydrostatic pressure exceeds oncotic pressure, fluid moves out. If oncotic pressure is higher, fluid moves in.
So let me ask you a question. In the arterial and venous end, is the net pressure the same?
Great question. No, it's not the same. On the arterial end, hydrostatic pressure is higher, so the net pressure pushes fluid out. On the venous end, hydrostatic pressure drops and oncotic pressure dominates, pulling fluid back in.
So the net pressure is not the same, but that conservation of energy, do we have conservation of pressure?
In the circulatory system, we don't have a strict conservation of pressure. Energy is lost as blood flows through vessels due to resistance, causing the pressure drop from arteries to veins. This is why arterial pressure is higher than venous pressure and why we have a net pressure difference.
Alrighty. Okay, let's talk about congestion.
Sure, congestion in a medical context often refers to an abnormal buildup of fluid, like in congestive heart failure. It happens when blood flow slows and backs up, causing fluid to leak into tissues like the lungs or legs. This can lead to symptoms like shortness of breath or swelling.
So pulmonary edema, is it a congestion?
Exactly. Pulmonary edema is a type of congestion where fluid accumulates in the lungs' air sacs. This happens when the heart can't pump efficiently, causing fluid to back up into the lungs. It leads to difficulty breathing and requires prompt treatment.
What about damming? What's damming?
Edema is swelling caused by excess fluid trapped in the body's tissues.
Chair.
It can occur any. Got it.
Damming.
Edema is.
Damming. Damming.
Gotcha. Damming, like creating a barrier, can be used metaphorically to describe how fluid builds up in one area when there's a blockage or restriction. It's similar to how a dam holds back water, causing a buildup.
So it's the same thing as congestion then.
Pretty much, both terms describe fluid buildup, but congestion is more commonly used in medical contexts, like with the lungs, while damming is more metaphorical.
And backwards theory? What's backwards theory?
Backward theory often relates to how fluid moves backward due to pressure changes, like in heart failure. When the heart can't pump effectively, blood backs up into the veins, raising pressure and causing fluid to leak into tissues. This backward movement leads to congestion.
I don't understand the difference.
No problem. In simple terms, backward theory is about how fluid can back up in the body when the heart isn't pumping well, leading to congestion in areas like the lungs.
I see. Okay. Yeah, so basically if we have congestion inside the lungs, then the fluid gets in the alveoli.
Exactly. When congestion occurs in the lungs, fluid seeps into the alveoli, making it hard to breathe. This is what happens in pulmonary edema.
Okay, so if we have a blockage of venous return to the right heart, what happens?
If there's a blockage in venous return to the right heart, blood backs up into the veins, increasing pressure. This can cause swelling in the legs, liver congestion, and even fluid buildup in the abdomen, known as ascites.
So left side heart failure will cause pulmonary edema.
Exactly. Left sided heart failure causes blood to back up into the lungs, leading to pulmonary edema. This results in fluid in the
But
alveoli,
but
making breathing difficult.
but not right side.
Correct. Right sided heart failure usually causes systemic congestion, like swelling in the legs or abdomen, not pulmonary edema.
Mm-hmm.
Exactly. Each side has its own effects.
Alrighty.
Glad it makes sense.
A new background, lol. Um, let's continue, sir. Are you ready? Sorry, guys, I took a break.
No problem. Ready when you are.
All right. So, what's going on with congestion in terms of you mentioned ascites? Explain it, please. And also ankle edema. So, it's due to gravity, basically, the ankle edema.
Sure. Ascites is fluid buildup in the abdomen, often from liver issues or heart failure. Ankle edema is swelling in the lower legs, often due to gravity and poor venous return, especially in right-sided heart failure.
So, ascites is in the peritoneal cavity.
Exactly. Ascites is fluid accumulation in the peritoneal cavity, often due to liver disease, heart failure, or other conditions causing pressure imbalances.
What about congestion inside the hepatic portal system?
Congestion in the hepatic portal system, often from liver disease or right-sided heart failure, increases pressure in the liver's blood vessels. This can cause fluid to leak into the abdomen, leading to ascites.
Uh huh.
Exactly. It's all connected.
Can you talk to me more about the hepatic portal system? Do we have basically double capillary networks?
Sure. The hepatic portal system has a unique setup with two capillary networks. Blood from the digestive organs first goes through capillaries in the gut, then travels via the portal vein to the liver, where it passes through another set of capillaries before entering the systemic circulation.
Tell me one more time, sir.
Sure. Blood from the digestive organs first enters capillaries in the gut, then it travels through the portal vein to the liver, where it passes through another set of capillaries before entering the systemic circulation.
Mm-hmm.
You're
Interesting.
welcome. It really is.
Alrighty, let's talk about hydrogen ions and HCO3 and yeah, kidney and lung balance, pH, plasma.
Sure. Hydrogen ions and bicarbonate, HCO3 minus, are key for maintaining blood pH. The kidneys regulate bicarbonate, while the lungs control CO2 levels, balancing pH through respiration and excretion.
So what's going on with this H plus HCO3 minus stuff?
Hydrogen ions, H plus, make blood more acidic, while bicarbonate, HCO3 minus, acts as a buffer to neutralize acids. The balance between them maintains the blood's pH, with the lungs and kidneys working together to keep it stable.
And carbonic anhydrase, what does that do?
Carbonic anhydrase is an enzyme that helps convert CO2 and water into carbonic acid, which then quickly splits into hydrogen ions and bicarbonate. This reaction is crucial for maintaining acid-base balance and is vital in tissues like the lungs and kidneys.
Wait, so carbonic anhydrase is the catalyzer?
Exactly. Carbonic anhydrase catalyzes the conversion of carbon dioxide
We
and
don't,
water to
we
carbon.
don't, we don't say catalyzer, catalyst, sorry.
Right? It's an enzyme that acts as a catalyst, speeding up the chemical reaction.
Okay, so, so wait, so we have, it's H2CO3 then?
Yes, H2CO3 is carbonic acid formed from CO2 and water, and it dissociates into H plus and HCO3 minus.
What does anhydrase mean?
Anhydrase refers to an enzyme that removes water during a chemical reaction. In carbonic anhydrase, it helps convert water and CO2 into carbonic acid efficiently.
Oh, dude.
Yep, it's all about speeding up those reactions.
So the kidney tubule conserves HCO3 and eliminates H plus.
Exactly. The kidney tubules reabsorb bicarbonate, HCO3 minus, and excrete hydrogen ions, helping maintain the acid-base balance
Why?
to keep your blood pH balanced and stable.
So they absorb HCO3. Well, why not the other way around?
Reabsorbing bicarbonate and excreting hydrogen ions helps neutralize acids, keeping pH stable. Doing it the other way would make the blood more acidic.
Well, why? Well, why is it that? H plus is the one in excess and we need to like excrete it and not HCO3 being in excess.
H plus is often in excess due to metabolism producing acids. Bicarbonate acts as a buffer to neutralize these acids, so excreting
Okay.
H plus pH.
And so question, why is it in excess? Is it because of CO2 in the atmosphere?
Not exactly. It's mainly from normal metabolic processes in the body, which produce acids like lactic acid or carbonic acid. The body constantly produces H plus, which needs to be balanced by bicarbonate and excreted by the kidneys.
Tell me again.
Sure, your body's metabolism produces acids like lactic acid. This creates excess hydrogen ions, H plus, which need to be balanced by bicarbonate and excreted by the kidneys to maintain pH balance.
Does the kidney always excrete H plus, or sometimes it's if the organism is too basic, it will excrete HCO3 minus?
The kidneys primarily excrete H plus to maintain pH balance. However, if the blood becomes too basic, they can also excrete bicarbonate, HCO3 minus, to lower the pH and restore balance.
And how do they excrete it? Is it through the glomerulus or is it through secretion and active transport to the distal tubule or whatever?
Is mainly excreted via secretion in the renal tubules. It's actively transported into the tubule from the blood, especially in the distal tubule and collecting duct, where it's then eliminated in urine.
Alrighty.
You got it. It's all about balance.
So if the GFR is low because of some kind of problem, where are the acids retained?
If GFR is low, the kidneys can't filter blood as effectively, so acids, including H+, can build up in the blood, leading to metabolic acidosis.
Tell me again.
Sure, when GFR is low, the kidneys can't remove acids efficiently, so acids like H+ accumulate in the blood, causing metabolic acidosis.
One more time.
No problem. If GFR is low, the kidneys struggle to filter out acids, leading to a buildup of H+ in the blood, which can cause metabolic acidosis.
Yeah, brother, tell me again.
Sure thing. If GFR is low, acids like H+ aren't filtered out well, so they build up in the blood.
Yes. Got that. But I'm just saying, where exactly is the build-up happening? Is it in my head? Is it in my legs?
I got it. The buildup happens in the blood throughout the body. It can affect various tissues, leading to symptoms like fatigue, confusion, or shortness of breath.
Where exactly in the blood?
The buildup of H+ is systemic, meaning it occurs throughout the bloodstream, not just in one specific area. This affects the entire body's acid-base balance. All right. So when the glomerular filtration rate is low, the kidneys struggle to remove hydrogen ions from the blood. This leads to hydrogen ions accumulating, mainly in the form of bicarbonate buffering. This excess H plus causes acidosis, leading to a lower blood pH. The kidneys usually compensate by reabsorbing bicarbonate, but with low filtration, that process is hampered, resulting in more H plus staying in the blood.
So if the renal tubular failure occurs, so the tubules don't do active transport to get rid of the acid, how can renal tubule failure occur? Also, if how can tubules allow too much bicarbonate to escape into urine? How can these things happen? Tell me specifically. Don't talk to me generally, please.
Sure, renal tubular failure can occur due to damage or dysfunction in the tubule cells, often from conditions like acute tubular necrosis, interstitial nephritis, or genetic disorders. When the tubules are damaged, they can't actively transport hydrogen ions out or reabsorb bicarbonate efficiently. This results in either acidosis if acid isn't secreted or alkalosis if too much bicarbonate is lost in the urine. Specific causes include ischemia, toxins, or inherited conditions like Fanconi syndrome.
Tell me again.
All right, so renal tubular failure can happen when the tubule cells are damaged, often due to conditions like acute tubular necrosis or interstitial nephritis. When this happens, the tubules can't actively secrete hydrogen ions or reabsorb bicarbonate properly. This can lead to acidosis if acid isn't removed, or alkalosis if too much bicarbonate is lost. This damage can be caused by things like lack of blood flow, toxins, or genetic issues.
Uh, Go deeper.
Sure, let's dive deeper. Renal tubular failure occurs when the cells lining the tubules are damaged. This can be due to ischemia, where reduced blood flow deprives cells of oxygen, or toxins like certain medications. Inherited conditions, like Fanconi syndrome, can also cause dysfunction. When tubule cells are impaired, they can't reabsorb bicarbonate or secrete hydrogen ions effectively. This disrupts acid-base balance, causing metabolic acidosis if H plus accumulates, or metabolic alkalosis if bicarbonate is lost.
Alrighty.
Great! If you have more questions or need further clarification, just let me know.
Let's talk about acute kidney injuries.
Absolutely. Acute kidney injury, or AKI, happens when the kidneys suddenly can't filter waste from the blood. This can be due to things like severe dehydration, infections, certain medications, or reduced blood flow to the kidneys. Symptoms often include decreased urine output, swelling, fatigue, and confusion. It's crucial to identify and treat the underlying cause quickly to prevent further damage.
How about if you punch me in the kidney? Would that happen?
A single punch might not directly cause AKI, but severe trauma could lead to kidney injury.
What if
Typically,
it's Mohammed?
AKI.
Wait, what if it's Muhammad Ali punching?
Well, if someone with that kind of strength hits your kidney, it could definitely cause serious injury. AKI typically involves internal factors, but major trauma could contribute. Best to avoid that situation entirely.
Alright, metabolic versus respiratory acidosis. Please, anion gap. Let's talk.
Sure, metabolic acidosis happens when there's excess acid or bicarbonate loss, often from kidney issues or diarrhea. Respiratory acidosis occurs when lungs can't remove CO2 efficiently, like in COPD. The anion gap helps differentiate causes. A high gap suggests conditions like lactic acidosis, while a normal gap points to bicarbonate loss. Understanding these helps guide treatment.
Tell me more.
Sure, for metabolic acidosis, a high anion gap can indicate things like ketoacidosis, lactic acidosis, or ingestion of toxins. A normal anion gap often points to renal tubular acidosis or diarrhea. In respiratory acidosis, causes are typically lung related, like chronic
Well,
obstructive
what's the
pulmonary disease.
difference between metabolic and respiratory, though?
The key difference is the underlying cause. Metabolic acidosis results from excess acid production or bicarbonate loss, often involving the kidneys. Respiratory acidosis is due to impaired CO2 elimination by the lungs. Both affect blood pH, but stem from a different systems,
Wait,
requiring
one is
distinct.
because of, you say, the lungs, and the other because of the kidney.
Exactly. Metabolic acidosis typically relates to kidney function, like when the kidneys can't remove enough acid or lose bicarbonate. Respiratory acidosis, on the other hand, is due to the lungs not expelling CO2 effectively, leading to CO2 buildup in the blood. Both disrupt the body's acid-base balance, but the source differs.
Mhm. Where are the kidneys anatomically in the body?
The kidneys are located in the back of your abdomen, on either side of your spine, just below the ribcage. They're tucked in a space called the retroperitoneal space, which means behind the peritoneum. The
So,
lining of your abdominal.
so are they? Oh. Are they inferior of the diaphragm?
Yes, exactly. The kidneys are situated just below the diaphragm. They sit on either side of the spine, around the level of the lower ribs, in the upper lumbar region.
Uh-huh.
Glad that
Okay.
makes sense.
So what are uremic solutes?
Uremic solutes are waste products that accumulate in the blood when the kidneys can't filter them out properly. These include substances like urea, creatinine, and other nitrogenous wastes. When these solutes build up, they can cause symptoms like fatigue, nausea, and confusion, often seen in advanced kidney failure.
Mm-hmm.
Yep, it's a sign the kidneys need help.
So why in acute kidney injury we have high anion gap? Um, so I think this is because if uremic solutes accumulated, but in renal tubule failure, no, we have normal anion gap.
Exactly. In acute kidney injury, the high anion gap is often due to the accumulation of acids like urea and creatinine. In
Le-
renal tubular failure, the tubules are damaged, but the glomeruli might still function. So bicarbonate reabsorption is affected, resulting in a normal anion gap, but still causing acidosis.
Anion gap is the difference of unmeasured acids.
Exactly. The anion gap measures the difference between primary measured cations, like sodium, and anions, like chloride and bicarbonate, in the blood.
So
A
it's the
high
difference
anion gap,
between unmeasured cations and unmeasured anions.
yes, exactly. It's the difference between measured cations, like sodium, and measured anions, like chloride and bicarbonate.
Measured
When
or
this
unmeasured?
measured cations and anions are
Are
the
you
ones we routinely.
wait? Are you sure? I thought anion gap was the rest of them.
Yes, the anion gap represents the unmeasured anions, which are not routinely checked, like lactate or ketones.
All
A high
right.
gap
So
suggests there are more of these.
okay,
Exactly.
if we have a high anion gap, does this mean we have high cations or high anions?
A high anion gap means there are excess unmeasured anions, not cations. It suggests the presence of additional acids in the blood.
Wait, is it
You're
an
welcome.
anions minus cations or the other way around?
It's typically cations minus anions. For example, sodium minus the sum of chloride and bicarbonate.
I don't understand, dude. Why? How can a higher be more anions?
I get it. It's a bit tricky. The high refers to the gap between measured cations, like sodium, and measured anions, like chloride and bicarbonate. A larger gap means more unmeasured anions are present.
No, I don't get it. I don't get it because i- if it's anions minus cations, if the anion gap is 12, let's say we have 16 cations and wait, is it so it's cations minus anions?
Yes, exactly. The anion gap is calculated by subtracting the sum of measured anions, like chloride and bicarbonate, from the main measured cation, sodium. If the result is higher, it means there are more unmeasured
Dude,
anions
wait, I'm
present.
confused. I'm so confused. So the anion gap is measured anions minus fucking hell, dude.
It's okay. The anion gap is calculated as measured cations, mainly sodium, minus the measured anions, chloride and bicarbonate. A high gap means there are unmeasured anions.
So measured cations minus measured anions.
Exactly, that's correct.
And this is usually 12.
Yes, a normal anion gap is typically around 12, but it can range a bit depending on lab standards.
And what is this 12?
That 12 represents the average difference between measured cations, like sodium, and measured anions, chloride and bicarbonate in healthy blood.
What 12? 12 apples?
Haha, not apples. It's just a numerical value indicating the concentration difference in milliequivalents per liter.
Milli equivalents per liter?
Yes, exactly. It's a unit of measurement used to express the concentration of ions in the blood.
How do I write it?
You can write it as MEQL, short for milliequivalents per liter.
What?
MEQL, altogether.
The anion gap is confusing me because I'm not sure if it's unmeasured or measured.
The anion gap is definitely a measured value. It's calculated using the concentrations of sodium, chloride, and bicarbonate in the blood. If there's a gap, it typically means there's an excess of unmeasured anions, like lactate or ketones. Does that clear things up a bit?
So Na minus Cl minus bicarbonate is usually 12. If we have more unmeasured anions, let's say we'll have another minus 3, it's going to go to the other side and it's going to be 12 plus 3 equals 15. So if we have more anions that are unmeasured, this will lead to a high anion gap.
Exactly. The normal anion gap is typically around 8 to 12. When there are more unmeasured anions, like lactate, ketones, or certain toxins, the gap increases. This helps pinpoint the cause of metabolic acidosis. So, a higher number means there's something extra in the blood that isn't normally measured.
So in acute kidney injury, what's this extra in the blood? Huh?
In acute kidney injury, the kidneys struggle to filter out waste products. This can lead to a buildup of substances like urea, creatinine, and various electrolytes. This accumulation can cause a high anion gap due to unmeasured anions or other imbalances in the blood.
Again.
Sure, in acute kidney injury, the kidneys can't filter out waste properly. This causes a buildup of substances like urea and creatinine. These extra substances can lead to a high anion gap, indicating an imbalance in the blood.
I don't understand.
No worries. When kidneys are injured, they can't remove waste effectively. This causes waste products, like urea, to build up in the blood. This buildup can create a higher anion gap, which signals an imbalance.
I don't understand.
All right, let's simplify. When your kidneys aren't working well, waste builds up in your blood. This buildup changes the balance of certain chemicals, creating a higher anion gap. Does that help a bit?
No.
Okay. Think of your kidneys like a filter. If the filter isn't working, stuff that should be removed stays in the blood. This extra stuff changes the blood's balance,
But
making the anion
why
gap
is that?
bigger.
Yeah, but why is that stuff anions and not cations?
Great question. The substances that build up, like urea, are often neutral or negatively charged. This increases the unmeasured anions in the blood, raising the anion gap.
But wouldn't the retention of H plus also balance out the anion gap?
It might seem like it would, but the retained H plus ions typically contribute to acidosis. This acidosis results in more unmeasured anions, like lactate or phosphates, contributing to the higher anion gap.
Do we have ever lower anion gap?
Yes, a lower anion gap is possible, though it's rare. It can happen if there's a decrease in unmeasured anions or an increase in unmeasured cations, like in cases of hypoalbuminemia.
And is this called alkalosis?
Not quite. Alkalosis refers to a higher blood pH. A lower anion gap doesn't necessarily mean alkalosis. It usually signals something else, like low albumin levels or lab errors.
Hmm.
No problem. Alkalosis means the blood is more basic, with a higher pH. A low anion gap usually points to other issues, like decreased unmeasured anions. It's a separate concept from pH levels.
So why in the renal tubule failure we will have loss of HCO3 minus into urine?
In renal tubular acidosis, the kidneys can't properly reabsorb bicarbonate, HCO3-, leading to its loss in urine. This reduces bicarbonate in the blood, causing acidosis and potentially increasing the anion gap if other anions build up.
Where is the bicarbonate usually reabsorbed? What part?
Bicarbonate is mainly reabsorbed in the proximal tubule, PT, of the nephron. This is the first part of the nephron where most of the bicarbonate is reclaimed back into the bloodstream.
Mm-hmm.
So, when there's a problem in that area, bicarbonate isn't reabsorbed efficiently, which can lead to acidosis.
Then why would we have low blood potassium?
Low blood potassium, or hypokalemia, can happen because the kidneys excrete more potassium when they try to balance the acid-base disturbance. In acidosis, the body often shifts potassium into cells to maintain balance, lowering blood levels.
What do you mean?
Sure, when there's acidosis, the body tries to correct it by moving hydrogen ions into cells. To maintain electrical balance, potassium moves out of cells into the urine, lowering blood potassium.
Uh-huh. Got it. So we pee more potassium because there's so much hydrogen around.
Exactly. The kidneys excrete more potassium to balance out the extra hydrogen ions. This helps correct the acidosis, but it can lead to lower potassium levels in the blood.
What's non-anion gap hyperchloremic metabolic acidosis? Let me try and think about it. Well, it's metabolic, so we have a problem with the kidney. We have a buildup of acid since it's acidosis. We have a lot of chloride in the blood, which this is the part that confuses me, and we have non-anion. So we don't have higher unmeasured anions or cations, or maybe they cancel each other out. So let's think how this would happen. There's a problem with the kidney. We pee a lot of bicarbonate. There's low bicarbonate in the blood, so there's a buildup of chloride in the blood to maintain electric charge balance. So then the non-ion anion gap metabolic acidosis. I don't know why it's non-anion though. Because yeah, tell me.
Non-anion gap metabolic acidosis means there's acidosis without a rise in unmeasured anions. It usually happens when bicarbonate is lost, like in renal tubular acidosis or diarrhea. Chloride increases to maintain electrical neutrality, keeping the anion gap normal.
But I thought that chloride is part of the anion gap. So if chloride concentration changes, anion can't be changed.
Yes, chloride is part of the anion gap calculation. But in non-anion gap acidosis, the drop in bicarbonate is matched by a rise in chloride. This keeps the overall
Oh,
anion gap stable,
got it, got
hence the
it.
term gap.
All right, let's continue then.
All right, let's keep going.
So, um, uh,
What's next on your mind? Take your time.
renal artery occlusion, renovascular hypertension. Can you talk to us about that? Also, talk to me about the connections of the renal artery to other things.
Sure, renal artery occlusion is a blockage in the artery supplying blood to the kidneys. This can lead to renovascular hypertension, which is high blood pressure caused by reduced blood flow to the kidneys. This triggers the release of renin, which ultimately increases blood pressure. The renal artery is also connected to other systems, like the adrenal glands, which can affect blood pressure and electrolyte balance.
And what's parenchyma?
Renal parenchyma refers to the functional tissue of the kidneys, which includes the cortex and medulla. It's responsible for filtering blood, forming urine, and maintaining electrolyte balance. Damage to the parenchyma can affect kidney function.
Wait, what? You said medulla and?
The renal parenchyma consists of the cortex and medulla. The cortex is the outer layer, and the medulla is the inner part. Both are vital for kidney functions like filtering blood and producing urine.
Mm-hmm.
Exactly. The cortex and medulla work together to handle filtration, reabsorption, and secretion.
Furosemide?
Loop diuretics like furosemide work on the medulla's thick ascending limb, inhibiting sodium reabsorption. This increases urine output, helping to reduce fluid buildup.
What is furosemide?
Furosemide is a diuretic medication that helps your body get rid of excess salt and water. It does this by acting on the kidneys to increase urine production. It's often used to treat conditions like edema and hypotension.
What is it?
Furosemide, also known as Lasix, is a loop diuretic. It works by blocking sodium reabsorption in the kidneys, which increases urine output. This helps reduce fluid retention and lower blood pressure.
Why is it called furosemide?
The name furosemide comes from its chemical structure. The furo part refers to a furan ring in the molecule, and semide indicates its sulfonamide group. These parts make up its full chemical name.
Mm-hmm.
Interesting, right? Anything else you'd like to know about it?
What's a loop diuretic?
A loop diuretic is a type of medication that acts on the loop of Henle in the kidneys. It blocks sodium reabsorption, causing more sodium, water, and other electrolytes to be excreted in the urine. This helps
Thiazide.
reduce.
What about thiazide and thiazide-like diuretics?
Thiazide diuretics work differently. They act on the distal convoluted tubule of the nephron, reducing its sodium reabsorption there. This helps lower blood pressure and manage fluid retention.
And
Thiazide-like diuretics,
I don't want to
they
memorize
can.
I don't want to memorize that indapamide is a thiazide like diuretic.
No worries. Just remember that thiazide-like diuretics, like indapamide, work similarly to thiazides, but may have slightly different properties or duration of action.
But I don't understand. Okay, okay. I don't have time to go into details, unfortunately, guys. But I'm gonna do a big drag episode. Okay. Potassium ion sparing. What is this? Spironolactone.
Potassium-sparing diuretics, like spironolactone, help the body retain potassium while still promoting water loss. They work by blocking aldosterone, which reduces sodium reabsorption and prevents potassium loss, often used to treat heart failure or hypertension.
Mm-hmm.
Spironolactone blocks aldosterone, a hormone that causes sodium retention. By blocking it, spironolactone helps your body excrete sodium and water while retaining potassium. It's often used for heart failure, hypertension, and conditions like hyperaldosteronism.
All right. So hypervolemia, we have too much volume, basically.
Exactly. Hypervolemia means there's too much fluid in the blood. It can cause high blood pressure, swelling, and strain on the heart.
And,
Diuretics like spironolactone.
and why is it a homeostatic response to CHF?
In congestive heart failure, CHF, the body perceives reduced blood flow as low volume. To compensate, it activates mechanisms to retain sodium and water, increasing blood volume.
Wait, I
This
thought that congestive heart failure is too much fluid.
You're correct. CHF does involve excess fluid. The body mistakenly thinks there's low blood flow, so it retains more fluid, worsening the problem.
Oh,
Diuretics
wow.
help
So
counteract.
it's doing the wrong thing.
Exactly. The body's response is well intentioned, but ends up causing more fluid buildup,
But
making it
why does
CHF.
the body do this? I don't understand why it thinks that this is a correct response.
It's because the body interprets reduced cardiac output as low blood volume. It triggers these responses to maintain blood pressure and perfusion to vital organs.
Tell
It's a
me,
protective
tell me
mechanism.
again, tell me again.
Sure, the body senses reduced cardiac output in CHF as low blood volume, so it tries to compensate by retaining fluid to boost blood pressure and circulation. It's a protective response, but in CHF, it backfires.
Tell me one more time.
Absolutely. In CHF, the body thinks there's not enough blood flow, so it retains fluid
Why
to
does the
increase.
body thinks there is not enough blood flow?
The body detects reduced cardiac output, meaning the heart isn't pumping enough blood. This triggers a response to retain fluid, thinking it needs to boost blood volume to maintain
I
circulation.
see, I see. That makes sense.
Glad it helps.
Okay,
It's
guys,
all
let's
about the
talk more about how the cardiovascular system fails.
Sounds good. There's a lot to cover about how the heart and vessels can struggle. Where would you like to start?
Hmm, good question.
Maybe we can start with heart failure, or we can talk about atherosclerosis. What interests you most?
Give me a sec.
No problem. We can start wherever you're comfortable. Heart failure, atherosclerosis, or something else
So,
entirely. Your
ischemic
call.
versus hemorrhagic.
Great choice. Ischemic events, like heart attacks and strokes, happen when blood flow is blocked. Hemorrhagic events involve bleeding, like a ruptured blood vessel. Both can damage tissues, but
So,
the
so,
causes and
so talk to me about a stroke, let's say that's hemorrhagic, not ischemic.
Sure, hemorrhagic stroke occurs when a blood vessel in the brain ruptures, causing bleeding. This can result from high blood pressure, aneurysms, or trauma. The bleeding compresses brain tissue, causing damage. Treatment focuses on stopping the bleed and relieving pressure.
So, percutaneous, oh, this PCI, I always forget what the CI is.
No problem. PCI stands for percutaneous coronary intervention. It's a procedure to open narrowed or blocked coronary arteries, often with a stent, to restore blood flow to the heart.
I see. So, we have percutaneous coronary intervention. And so, what do we exactly do?
In PCI, a thin catheter is inserted through a blood vessel to the heart. A balloon is then inflated to open the blocked artery, and a stent is often placed to keep it open. This restores blood flow to the heart muscle.
Tell me again what exactly happens.
Sure, during PCI, a catheter with a balloon at the tip is threaded to the blocked artery. The balloon is inflated to push the plaque aside,
What
widening
is,
the artery.
okay, okay, got it. What is balloon angioplasty then?
Balloon angioplasty is the part of PCI where the balloon is inflated inside the blocked artery. This inflation compresses the plaque against the artery walls, widening the vessel to improve blood flow.
Okay,
Glad that makes sense. Anything else you'd like to know?
so much.
No rush. We can take it step by step.
The larger the vessel, the greater the wall tension. That makes sense.
Exactly. That's based on the law of Laplace, which states that wall tension increases with vessel radius. Larger vessels need more tension to withstand pressure, which can impact conditions like aneurysms.
So we talked yesterday about shear force. Can we talk about compressive and tensile force?
Sure, compressive force pushes inward, like squeezing. Tensile force pulls outward, like stretching. Both are important in understanding how blood vessels handle pressure and why vessel walls need to be strong yet flexible.
One more time.
So, compressive force squeezes the vessel, and tensile force stretches it. Both forces affect how vessels respond to pressure and blood flow.
So in a in a graph, we have aortic press x-axis, delta V on y-axis, and we're comparing compliance in two graphs. Why do we have a bigger x-axis width on the one with low compliance? We have a steeper slope on high compliance.
In a compliance graph, Wider x-axis pressure with a smaller y-axis volume change indicates lower compliance. This means the vessel doesn't expand much with pressure. A steeper slope with higher compliance shows the vessel expands more easily.
That makes sense. And so in laminar flow, it's slower at edges because of friction.
Exactly. In laminar flow, the fluid goes slower near the vessel walls due to friction, while the flow is faster in the center. This difference creates a parabolic velocity profile.
Dude, endothelium has so many activities.
Absolutely. The endothelium is incredibly active, regulating blood flow, clotting, and immune function, and even producing substances like nitric oxide to keep vessels healthy.
Okay, I'm going to talk about six things. Let's go the first two. Blood vessel tone, fluid filtration. How come the endothelium works towards this?
Great. For blood vessel tone, the endothelium releases substances like nitric oxide to relax vessels and endothelin to constrict them. For fluid filtration, it regulates permeability, allowing or restricting fluid and solute movement through the vessel wall.
One more time.
Sure, the endothelium adjusts vessel tone by balancing, relaxing, and constricting factors. For fluid filtration, it controls what passes through the vessel wall, maintaining tissue fluid balance.
I don't understand.
No problem. The endothelium releases chemicals to either relax or tighten blood vessels. It also controls how much fluid can pass through the vessel walls, helping maintain fluid balance in tissues.
Fluid, okay, that makes sense.
Great.
What is cerebrospinal fluid?
Serosanguineous fluid is a mix of serum and blood, often seen in wounds or inflammation. It's usually pale yellow with a small amount of blood,
Wait,
giving it a pink.
cerebrospinal fluid, where exactly is it?
Oh, cerebrospinal fluid. It's a clear, colorless fluid that surrounds the brain and spinal cord. It cushions the brain, removes waste, and provides nutrients.
So it's in the brain only?
Not just the brain. Cerebrospinal fluid also surrounds the spinal cord, filling the spaces within and around both. It helps cushion and protect the entire central nervous system.
Hemostasis and white cell recruitment?
For hemostasis, the endothelium helps control blood clotting to stop bleeding. It releases factors that promote or inhibit clot formation. For white cell recruitment, it signals immune cells to move to areas of injury or infection.
What about hemostasis?
Hemostasis is tightly linked to endothelial function. The endothelium, which lines blood vessels, plays a critical role in maintaining blood fluidity. It produces substances that prevent clotting under normal conditions, like nitric oxide and prostacyclin. When the endothelium is damaged, it exposes underlying tissues, triggering platelet adhesion and the clotting
Makes
cascade
sense.
to form.
And same with white cell recruitment. So how come angiogenesis and hormone trafficking and transcytosis is linked to endothelium activities?
Great question. Endothelial cells are super versatile. In angiogenesis, they're key players since they line new blood vessels, supporting growth and repair. For hormone trafficking, endothelial cells help regulate which molecules pass from the bloodstream into tissues. Transcytosis is a process where they transport substances across their layers, ensuring precise delivery. So their activity is vital for these processes.
Tell me again.
Endothelial cells are crucial in forming new blood vessels, regulating what passes from blood to tissues, and transporting substances across their layer. This makes them key for angiogenesis, hormone movement, and transcytosis.
How do they do it?
Endothelial cells line the inside of blood vessels, creating a barrier. For angiogenesis, they divide and migrate to form new vessels. In hormone trafficking, they express specific receptors and transporters to allow hormones through. Transcytosis involves engulfing molecules on one side and releasing them on the other. All these functions depend on their surface proteins and the signals they receive.
Don't understand.
No problem. Endothelial cells have receptors that detect signals, like from growth factors. When they receive these signals, they respond by changing shape, moving, or forming new structures. They also have transport mechanisms to selectively move molecules across their barrier. It's all about responding to the right signals and using their built-in machinery.
How do they, what even is angiogenesis?
Angiogenesis is the process of forming new blood vessels from existing ones. It's crucial for growth, healing, and even in some diseases. It's driven by signals that tell endothelial cells to grow and form new vessel networks.
And what's transcytosis?
Transcytosis is when cells transport molecules across their interior. In endothelial cells, it's a way to move substances from the bloodstream to tissues or vice versa. The cell engulfs the molecule on one side, transports it in a vesicle, and releases it on the other side.
So, in myocardial infarction, can you talk to me about sympathetic activity?
Of course, after a myocardial infarction or heart attack, sympathetic activity ramps up to compensate for the heart's reduced pumping ability. The sympathetic nervous system releases adrenaline, which increases heart rate and contractility to maintain blood flow. This response can help short term, but might stress the heart if prolonged. So managing sympathetic activity is crucial in recovery.
What's the difference between adrenaline and noradrenaline?
Adrenaline, also known as epinephrine, and noradrenaline, or norepinephrine, are both stress hormones, but they have slightly different roles. Adrenaline is released from the adrenal glands and affects many organs, boosting heart rate and energy. Noradrenaline acts mainly as a neurotransmitter, focusing on blood vessels to increase blood pressure. Both are part of the fight or flight response.
I don't understand the difference.
Sure, adrenaline, or epinephrine, is more about increasing heart rate and energy, getting your body ready for action. Noradrenaline, or norepinephrine, primarily targets blood vessels to raise blood pressure. Both work together in the body's stress response.
So, they are both part of the sympathetic.
Exactly. Both adrenaline and noradrenaline are key players in the sympathetic nervous system. They help your body respond to stress. Right, exactly.
What is the difference in their chemical composition?
Chemically, both are catecholamines. But adrenaline has a methyl group attached to its nitrogen atom, while noradrenaline does not. This small difference changes how they interact with receptors and how they're used in the body.
Again,
Sure, chemically, adrenaline has a methyl group on its nitrogen, while noradrenaline doesn't.
okay,
This
and
subtle
this
difference.
and this makes them have different functions. Can you remind me in 10 words the difference in functions?
Sure, adrenaline boosts heart rate and energy. Noradrenaline mainly increases blood pressure.
How does it do blood? How does it increase blood pressure? And the other one, yeah.
Noradrenaline increases blood pressure by constricting blood vessels, which raises resistance. Adrenaline boosts heart rate and
How does
output.
it constrict blood vessels?
Noradrenaline binds to alpha receptors on blood vessel walls, causing them to contract, which narrows the vessels and raises blood pressure.
Alpha receptors causing them to contract.
Exactly. Alpha receptors trigger muscle contraction in blood vessel walls, narrowing them and increasing blood pressure.
All right. What's transudate?
The signal is transduced through the receptor, activating pathways inside the cell that cause the muscle fibers to contract.
Dude, transudate and exudate.
Yes, transduced means the signal is converted into a cellular response. And exerted means the resulting action, like muscle contraction.
Transudate and exudate. Pressures on balance from capillary fluid accumulation.
Yes, that's right. Transudate and exudate describe fluid accumulation. Transudate is protein poor fluid from pressure imbalances, while exudate is protein rich, often from inflammation.
Yeah. And pulmonary edema is transudate.
Pulmonary edema can be either, but it's often transudate from heart failure. If inflammation is involved, it could be exudate.
Why is it transudate? Why is it protein poor?
Transudate is protein poor because it results from pressure imbalances, like increased hydrostatic pressure or decreased oncotic pressure, pushing fluid out without large proteins.
I don't understand.
No worries. Transudate forms when fluid leaks out due to pressure differences, not because of inflammation. So it lacks large proteins found in inflammatory exudate.
I don't understand.
Okay, think of transudate like fluid seeping out due to pressure, like water from a sponge. It doesn't carry many proteins because it's just pushed out by pressure changes, not because of inflammation.
Bro, I'm so confused.
No problem. Let's simplify. Transudate forms when fluid leaks from blood vessels due to pressure, without inflammation. It has fewer proteins compared to exudate, which is linked to inflammation.
Can you tag it from a different angle? Because I don't understand. I've been studying for a long time and my brain is bananas.
Got it. No worries. Think of transudate as fluid that escapes from blood vessels because of pressure differences, like when your foot swells if you stand too long. It's mostly water with few proteins. Exudate is more like a fluid with proteins, often due to inflammation.
Why does inflammation mean that protein will escape too?
Inflammation makes blood vessels more permeable, allowing proteins and immune cells to escape into tissues. This protein-rich fluid is what forms exudate.
That makes sense.
Great, glad that helps.
Mhm.
You're doing great. It's a lot to take in, but you've got this.
Thank you.
Anytime. Happy to help.
Pulmonary edema, why do we have dyspnea? Okay, it's fair enough. We will have dyspnea, but okay, why? Is it because we have so much fluid and we cannot expire?
Exactly. Fluid in the lungs makes it harder for oxygen to move into the blood, causing shortness of breath. The fluid also makes breathing more difficult.
And can we have ascites with the left heart failure or is it only with the right heart?
Ascites is more common with right heart failure, but severe left heart failure can cause it too due to
Well,
increased pressure in the venous system.
let's talk about compensation and decompensation.
Sure, compensation is the body's way of maintaining balance, like increasing heart rate when blood pressure drops. Decompensation happens when these mechanisms can't keep up, leading to symptoms like fluid buildup or shortness of breath. Sure, compensation is the body's attempt to correct imbalances, like increasing heart rate. Decompensation is when these efforts fail, causing worsening symptoms.
Okay, so decompensation is when it fails, but is it always worse? Like, my question is, would it be better? So, Like, you know how you might not have enough money to pay your electricity. So let's say your bill is £1,000, and then you only have £500. That's decompensation, basically.
That's a good analogy. Decompensation is like being short on resources. When the body can't meet demands,
But it's my
symptoms get
point
worse.
is decompensation better than nothing?
Got it. Yes, compensation is definitely better than nothing. It helps maintain function and buys time. But if the underlying issue isn't addressed, decompensation can eventually occur.
I see. But yeah,
Exactly.
is decompensation better than nothing?
Decompensation is usually a sign that the body's struggling. It's not ideal, but it does signal something's wrong, prompting intervention.
Yeah,
So in a way,
if the body did nothing, you would die. So at least decompensation is something. Or is it like the examples we gave beforehand, where it's like positive feedback that worsens it? Or is it, or can decompensation be worse than nothing sometimes and better than nothing at other times?
I see what you mean. Decompensation can sometimes be better than nothing, as it shows there's an issue needing attention. Other times, it can worsen the situation, like a vicious cycle. So it really depends on the context.
So in cardiac remodeling, why do ACE inhibitors and spironolactone help?
Great question. ACE inhibitors help by reducing the workload on the heart and lowering blood pressure, which prevents further thickening or stiffening of the heart muscle. Spironolactone blocks a hormone called aldosterone, which can cause harmful remodeling. Together, they help slow or reverse changes, improving heart function and symptoms. Anything else you'd like to know?
Tell me again.
Sure. ACE inhibitors reduce the heart's workload and lower blood pressure, preventing harmful thickening. Spironolactone blocks aldosterone, which helps slow or reverse damaging changes. Together, they improve heart function and symptoms. Feel free to ask more.
I don't understand.
No worries. ACE inhibitors lower blood pressure, which eases the heart's effort and prevents harmful changes. Spironolactone blocks a hormone that causes damage, helping to protect the heart.
Okay,
Both work together.
I understand ACE inhibitors. It's just, dude, these drugs, I can't learn their names. And I need help. So spironolactone, we just did it like an hour ago, and I don't remember.
That's totally fine. Spironolactone is a bit of a mouthful. It's a potassium-sparing diuretic, meaning it helps your body get rid of excess fluid while holding on to potassium. It also blocks aldosterone, a hormone that can cause harmful effects on the heart. If the name's tricky, just remember it's for fluid and heart protection.
Blocks aldosterone, I remembered actually, but I didn't know it was also a case sparing.
Yes, it's potassium sparing, which is great because it helps maintain potassium levels. It's a handy combo for managing fluid without losing important electrolytes.
What's the difference between chronic low output heart failure and decompensated heart failure?
So, chronic low output heart failure means the heart isn't pumping enough blood long term, often due to weakened heart muscle. Decompensated heart failure is when chronic heart failure suddenly worsens, causing severe symptoms like fluid buildup. It's basically a flare up of heart failure.
What's the difference?
Sure, chronic low output heart failure is a long term condition where the heart doesn't pump enough blood. Decompensated heart failure means there's a sudden worsening of symptoms like fluid buildup, needing urgent care.
What's peripheral edema?
Peripheral edema is swelling in the limbs, usually the legs or ankles, caused by fluid buildup. It often happens when the heart can't pump blood effectively, leading to fluid leaking into tissues.
So is peripheral edema both for left and right heart side failure?
Yes, it can be. Right sided heart failure often causes peripheral edema because blood backs up in the veins. Left sided heart failure can also contribute indirectly as it progresses, leading to overall fluid overload. Sure, peripheral edema can happen in both right and left-sided heart failure. Right-sided failure directly causes swelling, while left-sided can contribute as it progresses.
I see. But I thought peripheral edema happens due to gravity.
Exactly. Gravity plays a role, especially when you're upright. Fluid tends to pool in the lower parts of the body,
Then
like the legs,
why is
and
peripheral edema more common in right side?
it's more common in right-sided heart failure because the right side pumps blood returning from the body. When it's weak, blood backs up in the veins, causing fluid to leak into tissues, especially in the legs and ankles.
I don't understand.
No problem. In right-sided heart failure, the right side of the heart struggles to pump blood from the body. This causes blood to back up in the veins, leading to fluid buildup and swelling in the legs and ankles.
I don't understand.
That's okay. In simple terms, right-sided heart failure means the heart can't
Yeah,
move
dude.
blood from.
But why is it more common in right side?
It's more common in right-sided heart failure because the right side pumps blood returning from the body. If it's weak, blood backs up in the veins, causing fluid buildup
Yeah,
and swelling
so
in the.
so it's not solely because of gravity then.
Right. It's not just gravity. It's mainly because the right side of the heart can't pump blood efficiently, which causes fluid to build up and lead to swelling.
What is central venous pressure?
Central venous pressure, or CVP, measures the pressure in the large veins near the heart. It reflects how much blood is returning to the heart and how well the heart is pumping. High CVP can indicate heart problems or fluid overload.
Tell me again.
Sure, central venous pressure, or CVP, is the pressure in large veins near the heart. It shows how much blood is returning and how well the heart pumps.
Outside
High
the right
CVP.
atrium.
Exactly. CVP is measured in the right atrium, or just outside it, giving a good picture of blood returning to the heart.
Cardiogenic shock. What is this?
Cardiogenic shock happens when the heart suddenly can't pump enough blood to meet the body's needs. It's usually due to severe heart damage, like from a heart attack, and can cause a dangerous drop in blood pressure.
What is it?
Cardiogenic shock is when the heart can't pump enough blood suddenly, often due to severe damage, leading to a big drop in blood pressure.
So what's the difference between the other things we talked about, like heart failure?
Good question. Cardiogenic shock is more severe and acute, with the heart suddenly failing to pump enough blood. Heart failure is a chronic condition where the heart gradually weakens over time, leading to fluid buildup and symptoms like
Wait,
edema.
can't we have acute heart failure?
Yes, we can. Acute heart failure is a sudden worsening of heart function, often due to things like a heart attack or severe illness.
So can
It can,
cardiogenic shock lead to heart failure?
yes, cardiogenic shock can cause or worsen heart failure if the heart is severely damaged and doesn't recover.
So question.
Sure.
Cardiomyopathy, myocarditis, endocarditis, or whatever it's called, cardiogenic shock, myocardial infarction, heart failure. How do all these things differ?
All right, let's break it down. Cardiomyopathy is a disease of the heart muscle. Myocarditis is inflammation of the heart muscle, often from infection. Endocarditis is an infection of the heart's inner lining. Myocardial infarction is a heart attack. Cardiogenic shock is when the heart suddenly can't pump enough blood. Heart failure is a chronic condition where the heart can't pump blood well over time.
So, do we have shock that's not cardiogenic?
Yes, there are other types of shock. For example, hypovolemic shock happens from severe blood or fluid loss. Septic shock is due to severe infection. And anaphylactic shock results from a severe allergic
And what
reaction.
does shock mean?
Shock means a critical condition where blood flow to tissues is dangerously low, depriving organs of oxygen.
So, what's the difference
It can.
between shock, and ischemia, or hypoxia, or hypoxemia?
Great question. Shock is a state of low blood flow. Ischemia is reduced blood flow to specific tissues. Hypoxia is low oxygen in tissues. Anoxia means no oxygen. Hypoxemia is low oxygen in the blood. Each term describes different aspects of oxygen or blood flow issues.
Wait, okay, listen.
I'm all ears. What's up?
Hypoxemia, low oxygen in blood, yes or no?
Yes, exactly. Hypoxemia means there's low oxygen in the blood.
And hypoxia is low oxygen in the tissues.
That's right. Hypoxia refers to low oxygen levels in the tissues.
And ischemia means low blood flow to tissues.
Yes, exactly. Ischemia is when there's reduced blood flow to tissues.
And then shock is what?
Shock is when the body has dangerously low blood flow, causing organs to not get enough oxygen.
So shock is a global ischemia.
That's a good way to think about it. Shock is like widespread ischemia affecting multiple organs due to low blood flow.
If we have ischemia in the whole body, can we call it ischemia or do we must call it shock?
If reduced blood flow affects the whole body and causes organ dysfunction, it's typically called shock. Ischemia usually refers to reduced blood flow in a specific area.
So why do we have positive feedback with cardiogenic shock?
In cardiogenic shock, poor heart function reduces blood flow, which lowers oxygen delivery to the heart itself.
Tell me
This further
again.
weakens. Sure. In cardiogenic shock, the heart can't pump well, reducing blood flow and oxygen to itself, which worsens its function in a cycle.
Why is it a positive feedback?
It's called positive feedback because each step amplifies the next. Poor heart pumping reduces blood flow, which worsens the heart's ability to pump, creating a downward spiral.
Got it. And why is it, what do we mean by SBP smaller than 90 millimeters mercury?
SBP stands for systolic blood pressure, which is the top number in a blood pressure reading. If it's less than 90 millimeters of mercury, it indicates very low blood pressure, which is a key sign of shock.
We need the pressure so the vessels don't collapse.
Exactly. Adequate blood pressure keeps vessels open and ensures blood flow to organs. When it's too low, like in shock, organs don't get enough blood.
You're so clever.
Right, exactly. Blood flow is crucial.
Why does the body make so much trouble for itself during heart failure?
The body's trying to compensate. For example, it increases heart rate and constricts blood vessels to maintain blood flow. But these efforts can sometimes backfire, making things worse.
So, why are ACE inhibitors, diuretics, and beta blockers chronic heart failure treatments?
They help reduce the heart's workload. ACE inhibitors lower blood pressure. Diuretics remove excess fluid. This makes it easier for the heart to pump and improve symptoms.
But surely ACE inhibitors and diuretics are given in different scenarios because diuretics means we have high blood pressure, but ACE inhibitors means we have high blood pressure. Sorry, it's the same thing.
You're right that both can lower blood pressure, but they have different roles. Diuretics reduce fluid buildup, which helps with symptoms like edema. ACE inhibitors relax blood vessels, making it easier for the heart to pump.
So, homeostasis for low cardiac outputs. I understand most of the things. Okay, let's talk about low output state versus low volume state.
All right. Low output state generally refers to conditions where the heart can't pump enough blood to meet the body's needs. Low volume state, on the other hand, refers to decreased blood volume, like in dehydration or blood loss. Both can cause similar symptoms like low blood pressure, but the management differs. Does that help clarify?
Yeah, that makes sense.
Great. If you want to dive into the causes or management of either state, just let me know.
Why do the capillaries leak fluid into tissues like lungs and ankles in decompensated heart failure?
In decompensated heart failure, the heart can't pump efficiently, causing blood to back up, increasing pressure in blood vessels. This pressure forces fluid out of capillaries into tissues, like the lungs or ankles, leading to edema. It's the body's response to the failing pump.
I don't understand.
No worries. Basically, when the heart struggles, blood pressure builds up, pushing fluid out of tiny blood vessels into surrounding tissues. That's why you see swelling in places like ankles or fluid in the lungs.
And again, I don't understand.
No problem. Imagine your heart as a pump. When it doesn't pump well, blood backs up in the veins. This extra pressure pushes fluid out of the smallest blood vessels into nearby tissues, causing swelling.
So it's like it's like because of the stretch we start having gaps.
Exactly. The increased pressure stretches the vessel walls, making them leakier, so fluid escapes into the tissues.
All right. So guys, we're gonna completely change the subject now. I wonder if I should do a new video about this. No, I'm just gonna name it. Because guys, I wanna talk. It's an interesting one. Well,
All
I'll figure it out anyway. But guys, we're gonna talk a bit about the mediastinum. Let's talk about the superior mediastinum. Are we ready?
Sure. The superior mediastinum is the upper part of the chest cavity, behind the sternum, and between the lungs. It contains important structures like the thymus, parts of the aorta, and major veins. Anything specific you want to discuss?
Well, so we have superior mediastinum and we have inferior mediastinum, yeah?
Exactly. The mediastinum is divided into superior and inferior sections. The superior mediastinum is above the heart, while the inferior mediastinum is below it, further split into anterior, middle, and posterior parts.
Okay, I'm confused with the middle. I understand anterior, posterior, but what do you mean middle?
No worries. The middle mediastinum houses the heart, pericardium, and major vessels like the
So is
ascending
the
aorta
middle
and
between the superior and inferior?
It's actually part of the inferior mediastinum, right in the middle of the chest, surrounding the heart.
And is the posterior and anterior part of the inferior too?
Exactly. The anterior mediastinum is in front of the heart, and the posterior is behind it, both part of the inferior mediastinum.
Well, I don't understand this. Why don't we have anterior half being in the superior and half being in the inferior?
That's a great question. The division is based on anatomical landmarks. The superior mediastinum is everything above the sternal angle, while the anterior mediastinum is below that level, in front of the heart.
Mm-hmm.
Glad that helped. Anything else about the
Yeah,
mediastinum?
I got what you mean. Okay, fair enough. Bit weird, but fair enough.
I'm glad it makes more sense. It's definitely
What is what structures are transected by the sternal angle?
the sternal angle, also called the angle of Louis, marks where the manubrium meets the body of the sternum. It aligns with the second rib and is at the level where the trachea bifurcates, the aortic arch begins and ends, and the superior mediastinum transitions to the inferior.
Well, we have arch of the aorta, bifurcation of the trachea, and T45.
Exactly. The sternal angle corresponds to the T4 T5 vertebral level. It's a key anatomical landmark for these structures. Hey, what's happening?
So let's talk about we have inferior, it's transthoracic plane, anterior manubrium, posterior T1 to T4, 5 vertebral bodies, superior is superior thoracic aperture or thoracic inlet. What's all this? Are these the boundaries of the superior mediastinum?
Exactly. The superior mediastinum is bounded by those structures. It's the upper part of the mediastinum, located above the heart. The anterior boundary is the manubrium, the posterior is the T1 to T4 vertebrae, and the superior boundary is the thoracic inlet.
Well, that makes sense.
Awesome. Glad it does.
Manubrium, and then you said the manubrium will go. So then we will have after the manubrium inferiorly we have it to connect with the body of the sternum.
Exactly. The manubrium connects to the body of the sternum at the sternal angle, also known as the angle of Lewis.
So
This landmark,
T45 sternal angle is also transthoracic plane, same thing.
yes, the sternal angle aligns with the T4-T5 vertebral level and the transthoracic plane. It's a key anatomical landmark used to identify structures within the mediastinum.
Perfect.
Great. Anything else you want to dive into?
Dude, we're gonna be talking for the next 2 hours. Put your seatbelt on.
I'm ready. Let's do it.
All right, so we have
All right.
veins, we have organs, nerves, arteries, lymphatics. What are the contents of the superior mediastinum in each of these categories?
Sure. In the superior mediastinum, for veins, you have the brachiocephalic veins and the superior vena cava. For arteries, there's the aortic arch and its branches, the brachiocephalic trunk, left common carotid, and left subclavian. Nerves include the vagus, phrenic, and the left recurrent laryngeal nerve. The trachea and esophagus are the major organs. Finally, you have the thoracic duct for lymphatics.
Why is the trachea anterior to the esophagus?
The trachea is anterior to the esophagus because it's part of the airway, so it needs a direct path to the lungs. This positioning also allows the esophagus, which handles food and liquids, to be behind it, providing protection and a more flexible path for swallowing.
So with the superior vena cava branches off to what?
The superior vena cava is formed by the union of the left and right brachiocephalic veins. It then drains directly into the right atrium of the heart. Its main function is to return deoxygenated blood from the upper body to the heart.
And the left and right brachiocephalic veins branch off to what?
The left and right brachiocephalic veins are formed by the union of the internal jugular veins and the subclavian veins on each side. These veins collect blood from the head, neck, and upper limbs, channeling it into the superior vena cava.
What about the lymphatics?
For lymphatics in the superior mediastinum, the main structure is the thoracic duct. It drains lymph from most of the body into the venous system, typically at the junction of the left subclavian and internal jugular veins. There's also some smaller lymph nodes and vessels in this region.
Talk to me about the right lymphatic duct and the thoracic duct, please.
Sure, the thoracic duct is the main lymphatic vessel, draining most of the body. It empties into the venous system at the junction of the left subclavian and internal jugular veins. The right lymphatic
Wait,
duct,
what?
on the
What?
other hand,
Tell me again. So these connect to the blood vessels?
yes, exactly. Both ducts connect to blood vessels. The thoracic duct empties into the venous system at the junction of the left subclavian and internal jugular veins. The right lymphatic duct does the same on the right side, draining lymph from the upper right quadrant of the body.
Wait, I'm confused. How do the ducts are basically vessels, but are not vessels. They're called ducts.
Think of the ducts as special vessels for lymph. They're part of the lymphatic system, not the blood system, but they connect to veins. They collect lymph and then drain it into the bloodstream at specific points. So,
Why do they connect to lymph?
lymphatic ducts connect to veins to return lymph to the bloodstream. Lymph carries waste, immune cells, and excess fluid from tissues. By draining into veins, it helps maintain fluid balance and allows immune cells to enter the bloodstream.
And where is the connection? Where do they connect?
The connection happens at the junction of major veins. The thoracic duct connects at the junction of the left subclavian and internal jugular veins. The right lymphatic duct connects at the
Again,
same junction.
left subclavian.
Sure. The thoracic duct empties into the venous system at the junction of the left subclavian vein and the left internal jugular vein. This spot is where lymph re-enters the bloodstream.
So at the brachiocephalic.
Not quite. The thoracic duct connects at the junction of the left subclavian and left internal jugular veins. The brachiocephalic veins form from these two veins coming together.
So at the bifurcation then.
Exactly. The thoracic duct connects right where the left subclavian and left internal jugular veins join to form the left brachiocephalic vein.
Internal jugular etymology, please.
Sure, internal jugular comes from Latin. Jugular relates to the throat or neck, derived from jugulum, meaning little yolk or throat. Internal signifies it's deeper inside the neck as opposed to the external jugular vein, which is more superficial.
So the thoracic duct is at the bifurcation.
Yes, the thoracic duct empties into the venous system at the point where the left subclavian and left internal jugular
So
veins
so
meet.
it empties there, but where does it start?
The thoracic duct starts in the abdomen at a structure called the cisterna chyli, which is located near the first and second lumbar vertebrae.
What about
It
the
collects.
right lymphatic duct?
The right lymphatic duct is much shorter. It starts in the upper right thorax and drains lymph from the right upper quadrant of the body, the right side of the head, neck, chest, and right arm.
And
It empties into
where does that connect?
the right lymphatic duct connects at the junction of the right subclavian vein and the right internal jugular vein. This is where it empties lymph into the bloodstream.
Okay, are you sure it's at the bifurcation and not specifically in the subclavian when it comes to the thoracic duct?
Yes, I'm sure. The thoracic duct specifically empties at the junction of the left subclavian
Why do
and
you think
left.
this is the ideal? Why do you think this is the ideal location to empty?
It's an ideal location because it's a major vein junction, ensuring efficient lymph return to the bloodstream. This spot is also close to the heart, helping lymph mix quickly with blood circulation. Plus, the left subclavian vein has a large volume of blood flow, making it efficient.
The coronary arteries, I never can be able to locate them on the heart.
No worries. Coronary arteries branch off the aorta right after it leaves the heart. They wrap around the heart's surface, supplying blood to the heart muscle. The main ones are the left and right coronary arteries. The left splits into the left anterior descending and circumflex arteries.
All right, guys, so we're going to do a multitasking here, talking about valves too. I hope you don't mind. Um, so uh, I'm going to go back and forth, ChatGPT, talking about valves and the mediastinum. Is that okay?
Absolutely. We can multitask. Let's dive into valves and the mediastinum. What's
Why
on your
is,
mind?
why is S1 the lub and the S2 is the dub?
Exactly. The lub sound, S1, is from the mitral and tricuspid valves closing. The dub sound, S2, is from the aortic and pulmonary valves closing.
Why is it lub and dub and not dub and lub?
It's lub first because S1 marks the beginning of systole, when the ventricles contract. The mitral and tricuspid valves close first. Then S2 follows when the aortic and pulmonary valves close, ending systole.
So let's talk about the epidemiology of valvular heart disease. We have degenerative, we have infected, we have congenital, rheumatic. Tell us the differences.
Sure, degenerative valvular heart disease usually results from aging and wear. Infective types are due to infections like endocarditis. Congenital issues are present from birth, like malformed valves. Rheumatic heart disease stems from rheumatic fever, causing inflammation and scarring. Each type affects the valves differently.
Really?
Yep, each type has unique causes and effects on the heart.
Why do they affect the heart differently? Let's talk about rheumatic and infective, for instance.
Sure, rheumatic heart disease usually results from untreated strep infections, causing inflammation and scarring of the valves. Infected endocarditis, on the other hand, involves bacteria or other pathogens directly infecting the valve, leading to damage and sometimes abscesses.
How
Different
can
mechanisms.
okay, sorry guys. How unprofessional. How can post-streptococcal rheumatic fever? Why? What is it? Sorry, what is streptococcal?
No worries, streptococcal refers to bacteria from the Streptococcus genus. Certain strains, like group A streptococcus, can cause strep throat. If untreated, the immune response can mistakenly attack heart tissue, leading to rheumatic fever, which can damage heart valves over time.
So why is degenerative aortic and not mitral, and rheumatic is more mitral than aortic?
Degenerative aortic disease is often age-related, with wear and calcification. The mitral valve is more affected by rheumatic fever because its position and structure make it more susceptible to inflammation and scarring. The aortic valve can also be affected, but usually to a lesser extent compared to the mitral valve.
Um, so just a
Got
second.
more? Sure, take your time.
I always forget if mitral is right atrium or left atrium.
The mitral valve is on the left side, between the left atrium and left ventricle. It's the
Why,
valve that prevents backflow into the left atrium when the
why is
left
it
ventricle
why is it
contracts.
called mitral?
It's called the mitral valve because it resembles a bishop's mitre,
A
which is a
bishop?
type of ceremonial. Yep, the two flaps of the valve resemble the pointed hat, hence the name.
Uh-huh. Alrighty.
Interesting, right?
So why is rheumatic more mitral than aortic?
Rheumatic fever tends to affect the mitral valve more because of its structure and position. The high pressure in the left side of the heart makes it more susceptible to inflammation and scarring, which is common in rheumatic heart disease.
But I don't understand why mitral is more than aortic in rheumatic.
The mitral valve is more affected in rheumatic disease because it's exposed to higher pressures and turbulence. When the immune system attacks heart tissue, the mitral valve's structure makes it more vulnerable to scarring, while the aortic valve is somewhat protected by its position and structure.
I don't understand.
No problem. The key is that the mitral valve faces more stress, making it more likely to develop damage from inflammation compared to the aortic valve.
I can't lie, man. I still don't understand why degenerative is mainly on aortic and then rheumatic is mainly on mitral.
In simple terms, degenerative issues like calcification happen more in the aortic valve due to high pressure and age. Rheumatic disease affects the mitral valve more because of its structure and the type of damage caused by inflammation from rheumatic fever.
Okay, I get the aortic because of pressure, because it's gonna go to all the body, but why? I don't understand the mitral part.
Hey, so rheumatic heart disease often affects the mitral valve more than the aortic because the mitral valve is under higher pressure and more turbulent blood flow. This makes it more susceptible to the inflammatory process that happens in rheumatic fever. Over time, this can cause thickening or scarring,
One more
leading to
time.
issues like
Wait. I'm confused. I thought aortic is more pressure.
no worries. The aortic valve does handle high pressure, but the mitral valve is more prone to rheumatic damage due to its structure and blood flow dynamics. During rheumatic fever, the immune response targets the mitral valve more often, leading to
What's wrong with
scarring.
its structure?
Sure, the mitral valve has two leaflets, and it's between the left atrium and ventricle, handling blood flow from the lungs. It's more prone to the inflammation from rheumatic fever. The aortic valve is between the left ventricle and the aorta and has three leaflets. Its position means it faces high pressure, but the inflammation typically targets the mitral valve first.
I don't understand why rheumatic is more mitral. You say it's because of its structure, but what makes its structure more prone to rheumatic?
Got it. The mitral valve structure, with its two leaflets and location between the left atrium and ventricle, creates conditions where blood flow is more turbulent. This turbulence, combined with the immune response in rheumatic fever, leads to inflammation and scarring. The mitral valve's thin leaflets are more susceptible to this damage.
Why more turbulence?
The turbulence happens because the mitral valve manages blood flow from the left atrium to the left ventricle, a high pressure area. During rheumatic fever, the immune system's attack on heart tissues is more pronounced in areas with this kind of flow, causing inflammation and scarring in the mitral valve more often.
Well, excuse me, sir, but degenerative is aortic more than mitral. I don't understand why this difference.
No problem. Degenerative disease like calcification often affects the aortic valve more due to age-related wear and tear. The aortic valve faces high pressure and stress from pumping blood out to the body, leading to calcium buildup over time. The mitral valve, meanwhile, is more affected by rheumatic disease and less by degenerative changes.
Yeah, and I don't understand why. I feel you're not going deep enough. Can you go deep enough, please?
Sure, the aortic valve's location at the heart's outflow tract means it endures constant, high pressure blood flow, which over time can lead to wear, tear, and calcium deposits. This degenerative process, called calcific aortic stenosis, is linked to aging, wear, and sometimes conditions like hypertension. The
Sir,
mitral valve,
why is the mitral more common in rheumatic and the aortic more common in degenerative? I haven't gotten a good answer from you.
all right, let's break it down. Rheumatic fever often targets the mitral valve due to its structure and blood flow dynamics. The
Well,
immune response
what is
caused
different in the structure and blood flow dynamics of mitral than aortic?
the mitral valve has two leaflets and sits between the left atrium and ventricle, handling blood from the lungs. This area's turbulent flow makes it more vulnerable to rheumatic damage. The aortic valve has three leaflets, handles high pressure outflow to the body, and is more prone to wear, tear, and calcification over time.
What does rheumatic mean?
Rheumatic refers to conditions related to inflammation, typically stemming from rheumatic fever, an illness triggered by a streptococcal infection. It causes the immune system to mistakenly attack the heart, joints, skin, and brain, leading to inflammation and potential damage,
So,
especially to the
well,
heart valve.
why doesn't wear and tear occur in the aortic where we have high pressure?
Wear and tear does occur in the aortic valve, especially due to high pressure, leading to calcification and degenerative changes over time. This is why older adults often develop calcific aortic stenosis, where the valve stiffens and narrows due to calcium buildup.
All right. And how come con- how come we have an infective we have in the right atypical organisms IVDU and stuff like that?
Exactly. Infective endocarditis often affects valves damaged by conditions like rheumatic disease or degenerative changes. In IV drug users, bacteria can enter the bloodstream and typically affect the tricuspid valve on the right side of the heart due to direct exposure. Different organisms thrive depending on the conditions and valve
Why
involved.
are atypical organisms on the right side and not the left?
Right sided endocarditis, especially in IV drug users, often involves organisms like Staphylococcus aureus because the injected substances enter the bloodstream and reach the right heart first. The tricuspid valve is more commonly affected in these cases, while left sided infections are usually linked to pre existing valve disease.
Tell me again.
Sure, right sided endocarditis often involves organisms like Staphylococcus aureus because substances injected into veins go directly to the right heart. The tricuspid valve is typically affected. Left sided
Can we
infections
talk
usually.
about dilatation of valve ring as pathology?
Absolutely. Dilation of the valve ring, or cannular dilation, is when the ring like structure supporting the valve stretches out. This can happen due to conditions like heart failure, causing the valve leaflets to not close properly, leading to regurgitation where blood leaks backward. It often affects the mitral or tricuspid valves.
What is valve ring?
The valve ring, or annulus, is a fibrous, ring like structure that supports the valve leaflets. It helps maintain the shape and proper function of the valve, ensuring a good seal when the valve closes.
So, does it lead to stenosis or regurgitation?
Dilation of the valve ring usually leads to regurgitation. It prevents the valve leaflets from closing properly, allowing blood to flow backward. Stenosis, on the other hand, is typically caused by valve thickening or calcification, narrowing the valve opening.
All right, let's go back to the mediastinum.
Sure, the mediastinum is the central compartment of the thoracic cavity, housing the heart, great vessels, trachea, esophagus, and other structures. It's divided.
So the descending aorta has branches with posterior intercostal, bronchial, and others.
Exactly. The descending aorta gives off branches like the posterior intercostal arteries, which supply the chest wall, and bronchial arteries, which supply the lungs. It also has
Can we talk more about the descending aorta? How does it tell me about these biggest branches and let's go from there.
sure. The biggest branches of the descending aorta include the intercostal arteries, which supply the chest wall, the bronchial arteries for the lungs, and the esophageal branches. It
Yeah,
also
but
gives off abdominal.
do we have abdominal and thoracic aorta?
Yes, the aorta is divided into the thoracic aorta, which runs through the chest, and the abdominal aorta, which continues through the abdomen. Each section gives off branches supplying different organs and tissues.
I don't understand.
No worries. The aorta is like a major highway. The thoracic aorta runs through your chest, giving off branches to the chest wall and organs. Then it continues as the abdominal aorta, supplying blood to the abdomen and lower body.
I'm confused.
All right, let's simplify. The aorta has two main sections, the thoracic part in your chest and the abdominal part in your belly. Each part has branches that supply blood to different areas.
So, posterior intercostal, do we have anterior too?
Yes, we do. The anterior intercostal arteries come from the internal thoracic artery and supply the front part of the chest wall, while the posterior intercostals come from the aorta and supply the back.
Hmm.
Glad that helped. Any other questions about the aorta?
Let's talk about lymph duct.
Sure. The lymphatic system has two main ducts, the thoracic duct, which drains most of the body's lymph into the bloodstream, and the right lymphatic duct, which drains the upper right side. They help maintain fluid balance and immune function.
What's the difference between a duct and a trunk?
Lymphatic trunks are larger vessels that collect lymph from smaller lymphatic vessels and drain into the ducts. The ducts are the final pathways that return lymph to the bloodstream. The thoracic duct is the largest, draining most of the body's lymph.
Hmm.
Got it. Anything else you'd like to know about the lymphatic system?
So we have subclavian vein, and then around there we have the right lymphatic duct.
Exactly. The right lymphatic duct drains lymph from the upper right side of the body into the right subclavian vein. The thoracic duct drains into the left subclavian vein.
So it's at the right subclavian vein, very close to the bifurcation.
Yes, the right lymphatic duct enters the right subclavian vein near its junction with the internal jugular vein.
Why do you
This
think
spot,
God put it to the right subclavian vein and not to the internal jugular?
it's a matter of efficient drainage. The subclavian vein is a major vessel with a large capacity, making it a good spot for lymph
Excuse
to
me,
drain into.
sir. The internal jugular is not.
The internal jugular is also a major vessel, but the subclavian vein provides a more direct route for lymph from the thoracic duct. It's all about efficient flow and anatomical positioning.
Interesting.
Anything else you'd like to
And
explore?
then the duct branches off to trunk, subclavian one, and jugular.
Exactly. The right lymphatic duct drains into the junction of the right subclavian and internal jugular veins, ensuring smooth lymph return.
Wait a sec. So how is this possible? Because you told me duct is the ending bit and trunk is before. How can we have right subclavian trunk and right jugular trunk connect to right lymphatic duct? Ah, wait, I see. So basically it's the opposite direction with the normal blood vessels, the lymphatic ones are the opposite direction.
Exactly. Lymph flows in a one-way system. The right lymphatic duct collects lymph from the right upper body and returns it to the bloodstream, just like veins do, but in the opposite direction. So the trunks channel lymph into the duct, and then it empties into the venous system.
Okay, that makes sense, but why do we have opposite direction? And also, the other question I wanted to ask is, why do they interact with veins and not arteries?
Great questions. The opposite direction is because lymph carries fluid back to the bloodstream to maintain fluid balance and filter out waste. Veins have lower pressure compared to arteries, making it easier for the lymph to flow into them. Plus, veins bring deoxygenated blood back to the heart, so it's a natural spot for lymph to rejoin circulation.
One more time.
Sure, the lymphatic system returns fluid to the bloodstream to keep everything balanced. Veins have lower pressure than arteries, making it easier for lymph to flow in. Plus, veins return deoxygenated blood to the heart, so it's a natural place for lymph to rejoin.
That makes a lot of sense.
I'm glad it does. It's all about balance and efficiency in the body.
So the thoracic duct is lymph from lower limbs, abdomen and thorax, and then the lymphatic, the right lymphatic is from what, upper limbs?
Exactly. The thoracic duct drains lymph from the lower limbs, abdomen, and left side of the thorax, plus the left arm and head. The right lymphatic duct drains from the right upper limb, right side of the thorax, and the right half of the head and neck.
Hmm. Alrighty. And then we have the left bronchomediastinal trunk too, and the right bronchomediastinal.
Yes, exactly. The left and right bronchomediastinal trunks collect lymph from the thoracic region and then drain into either the thoracic duct or the right lymphatic duct, depending on the side.
Hmm.
It's a bit like a network of roads, each one leading back to the main highway.
Interesting. But okay, do we have left lymphatic duct?
There's no separate left lymphatic duct. The thoracic duct handles the left side and lower body, while the right lymphatic duct handles the right upper body.
Alright. C3, 4, and 5 keep the diaphragm alive.
Yes, exactly. The phrenic nerve.
So the phrenic nerve enters the superior mediastinum between the brachiocephalic veins and subclavian arteries. I wonder why this is the best location for it to enter the superior mediastinum.
Great observation. The phrenic nerve's path between the brachiocephalic veins and subclavian arteries is strategic. It's a protected route, ensuring the nerve can safely reach the diaphragm without being compressed.
Interesting.
It really is. The body's design has lots of clever
What
pathways like
what's
that.
the difference between motor supply and sensory supply? Because the phrenic nerve has motor supply to the diaphragm and sensory supply to the diaphragm, but also parietal pleura.
Good question. Motor supply means the nerve controls muscle movement, like the phrenic nerve telling the diaphragm to contract for breathing. Sensory supply means the nerve carries sensation signals, like feeling pain or stretch, from the diaphragm and pleura.
So motor is movement, sensory is sensation.
Exactly. Motors for action. Sensory is for feeling.
So how come sensory supply only to the diaphragmatic and mediastinal parietal pleura, and why specifically to the diaphragmatic and mediastinal parietal pleura? And yeah,
It's specific because the phrenic nerve is positioned to pick up sensations from those areas. The diaphragmatic and mediastinal pleura are near the diaphragm, so the phrenic nerve can sense irritation or pain there.
so why does the vagus nerve pass posterior to the main bronchi? What is the advantage?
The vagus nerve, passing posterior to the main bronchi, is advantageous because it can provide parasympathetic innervation to the lungs and other thoracic organs efficiently. This path also keeps it protected and close to the structures it innervates.
Well, why would an anterior work or inferior?
Anterior or inferior routes might expose it to more compression or damage. Posterior positioning provides a more protected path and a direct route to the organs it serves.
Why would it be less protective in other locations? Talk specifics.
Sure, anteriorly, it could be compressed by the heart or major vessels. Inferiorly, it risks compression or entrapment by the diaphragm and abdominal organs. The posterior path is more stable and direct to the thoracic organs.
Mm-hmm.
Makes sense, right? The body's got it all planned out.
Okay. Okay. Recurrent laryngeal branches traverse superiorly to provide motor supply to the larynx. Dude, you have to decode this.
Sure, the recurrent laryngeal nerves loop back up to the larynx to control the muscles there, enabling speech and swallowing. They take a longer route because they originally descended with the heart before the neck formed fully.
I don't even know what they are.
No worries, they're branches of the vagus nerve that help control your voice box or larynx. They also sense things like irritation.
Branches of the vagus nerve.
Exactly, they branch off from the vagus nerve and loop back up to the larynx.
Branches of the vagus nerve loop back into the larynx.
Exactly, it's a unique path they take, but it ensures they can reach the larynx.
Well, why do they need to do this loop? Can't it seems so inefficient.
It does seem inefficient, but it's a result of evolutionary changes. The loop happens because the nerve initially developed alongside the heart, and as the heart descended, the nerve was pulled down and looped around structures like the aorta.
What do we mean parasympathetic innervation via pulmonary, cardiac, and esophageal plexi?
Parasympathetic innervation means the vagus nerve helps control functions like heart rate, lung constriction, and digestion. The pulmonary, cardiac, and esophageal plexi are networks where these nerves spread out to provide these functions.
Hmm.
Yeah, it's a complex but fascinating system.
Why specifically via pulmonary, cardiac, and esophageal plexi? What even is plexi?
Great question. A plexus is a network of nerves. These specific plexi allow the vagus nerve to efficiently reach and innervate the lungs, heart, and esophagus, ensuring smooth parasympathetic control.
Tell me again what plexus is.
Sure, a plexus is simply a network of intersecting nerves.
What's the thymus?
The thymus is a small gland in the chest behind the sternum. It plays a crucial role in developing the immune system, especially during childhood.
Does everyone have it? Ah, it's present in children and then becomes smaller.
Exactly, it's most active in children and shrinks after puberty, becoming much smaller in adults.
And it's supplied by branches of the internal thoracic artery.
That's right, the thymus gets its blood supply from branches of the internal thoracic artery.
Ah.
Pretty interesting, right?
Why specifically of the internal thoracic artery?
The internal thoracic artery is nearby, making it a convenient source. It ensures the thymus gets the blood it needs for its immune functions.
And how big is the thymus in an adult?
In adults, it's quite small, often just a bit of fatty tissue weighing around 5 to 15 grams.
Do we even call it an organ in adults?
It's still technically an organ, but its function is minimal compared to childhood.
In childhood, what does it do?
In childhood, the thymus is crucial for developing T cells, which are essential for the immune system.
How would we develop T cells as adults then?
As adults, we rely on the T cells produced earlier, and our lymphatic organs maintain them. Our immune system has memory cells that last a long time.
One more time.
We depend on T cells made during childhood, and our immune system has memory cells that persist.
Mm. All right, let's talk about the boundaries of the anterior mediastinum while we're at it. So, yeah. So, as we talked before about the superior, so now we have the sternum as the anterior, we matched the superior, it will make sense, it's the sternal angle now. Okay, inferior is going to be the diaphragm, which is weird Because if the diaphragm is the anterior mediastinum's boundary, then what is the inferior mediastinum's inferior boundary?
Good question. The inferior boundary of the mediastinum is also the diaphragm. The mediastinum is divided into superior and inferior parts by the sternal angle.
Yeah, dude, but wait a sec, because we have anterior mediastinum, we have middle, we have inferior mediastinum, we have posterior. Wait, I'm confused.
No worries. The inferior mediastinum is divided into three parts: anterior, middle, and posterior. The middle part contains the heart. The anterior is in front of it, and the posterior is behind.
Okay, so all three are the have diaphragm as the inferior.
Exactly. All three parts share the diaphragm as their inferior boundary.
Genius. Okay, and why is posterior of anterior? Um, why is posterior boundary of anterior mediastinum in the pericardial sac?
Anterior mediastinum is bordered posteriorly by the pericardial sac because it sits right in front of the heart. The sac provides a clear boundary between the anterior mediastinum and the middle mediastinum.
So we have superior, and below that we have the middle, and in front we have the anterior, and behind the middle we have the posterior.
Exactly, you've got it. The superior mediastinum is above, with the anterior in front, the middle containing the heart, and the posterior behind.
So the middle contains the heart, so the anterior touches the front of the heart, and the posterior touches the back of the heart.
Exactly, the anterior mediastinum is in front of the heart, and the posterior mediastinum is behind it.
Booyakasha.
You got it. Great job.
Great job, guys. Great job. Jesus. Uh, okay. Guys,
No worries.
I'm so tired. But and I hate the idea that knowledge should be painful, but I mean, I have high ambitions, I guess. And I wanna anyway. Okay. Let's talk back to valves. Good intentions. Back to valves. Aortic stenosis. So we talked and said that aortic more wear and tear, so it's going to be more degenerative. We also have congenital syndromes, and it has to do with the wait a sec. Aortic stenosis. We're talking about the semilunar valve of the left heart, right?
Yes, exactly. Aortic stenosis involves the semilunar valve in the left heart, which controls blood from the left ventricle into the aorta.
Can we go into the mechanics of why this post-traumatic fever is so annoying with and causes aortic stenosis?
Sure, post traumatic fever, the body's immune response can damage the valve, causing it to thicken and scar. This leads to narrowing or stenosis, which obstructs blood flow.
Mm-hmm.
It's frustrating, but understanding the cause helps manage it.
Mm-hmm. Let's talk about the SAD triad.
Sure, the SAD triad in aortic stenosis stands for syncope, angina, and dyspnea, key symptoms of severe narrowing.
Why is it a triad?
It's called a triad because these three symptoms often appear together in severe aortic stenosis.
Mm-hmm.
It's a useful way to remember the main symptoms.
Okay.
Glad that helps.
All right. Pressure overload, generation of high LV systolic pressure to force blood through the obstruction.
Exactly, the left ventricle works harder, creating high pressure to push blood past the nailed valve.
Makes sense. Okay,
It
aortic
does.
stenosis heart sounds.
With aortic stenosis, you typically hear a harsh systolic murmur, often best at the right upper sternal border.
Tell me more about this.
Sure, the murmur is due to turbulent blood flow through the narrowed valve. It often radiates to the neck and can have a crescendo decrescendo pattern.
What is this crescendo decrescendo?
It means the murmur gets louder, then softer, like a swelling and fading sound.
Alrighty. So, tell me again about aortic stenosis heart sounds, please. This crescendo decrescendo, I don't understand it. So basically, you have a loud and then a quiet one?
Exactly. Crescendo decrescendo describes how the sound starts softly, then gradually increases to a peak, and then fades away again. It's often heard with murmurs like aortic stenosis. The crescendo is the building up part, and the decrescendo is the fading away. It sounds a bit like a wave.
And why does this occur? You explained that it occurs. Now we have to explain the meta of why.
Great question. The crescendo decrescendo pattern happens because of turbulent blood flow through a narrowed valve. In aortic stenosis, as blood is pushed through the narrowed opening, the flow becomes more intense, creating a louder sound. As the pressure changes and dynamics equalize, the intensity decreases, hence the decrescendo.
Tell me again.
Sure, the crescendo decrescendo pattern happens because blood flows turbulently through a narrowed valve. In aortic stenosis, as the heart pumps, blood has to squeeze through a smaller opening, creating a louder sound at peaks and then fades as the pressure changes.
One more time.
Of course, crescendo decrescendo happens when blood flows turbulently through a narrowed valve, like in aortic stenosis.
And why is
The
this in
sound
the beginning of systole where the pressure gradually rises?
That's because during systole, the left ventricle contracts and pressure builds up to push blood through the aortic valve. Initially, the valve is tight, so the flow is turbulent and creates a crescendo. As the ventricle relaxes, pressure drops, causing the decrescendo.
So why does the decrescendo? So okay, the crescendo occurs because of this turbulence, but I don't understand why the decrescendo occurs.
The decrescendo happens as the pressure in the left ventricle decreases after its peak. As the ventricle finishes contracting, less blood is forced through the narrowed valve, so the intensity of the sound naturally fades away.
I don't understand.
Think of it like this: as the heart contracts, it pushes blood through the narrowed valve, creating that crescendo. When the contraction ends and the pressure drops, less blood moves through, so the sound fades, creating the decrescendo. Squeezing, the pressure drops, so the sound naturally fades, creating a decrescendo.
Okay, that makes sense. And in severe cases, we basically have a soft sound in general because the stenosis is basically nothing. It's so big stenosis.
Exactly. In severe aortic stenosis, the opening is so narrow that the blood flow is more restricted. This can cause the murmur to be softer or even harder to hear, despite the severity, because less blood is getting through.
Mhm. So in
Yep,
aortic regurgitation, left ventricle dilatation occurs to accommodate volume because of volume overload. I don't understand this left ventricle dilatation.
sure. In aortic regurgitation, the valve doesn't close properly, allowing blood to leak back into the left ventricle. This causes volume overload. To handle this extra blood, the ventricle dilates or enlarges. This helps it pump out more blood with each beat, compensating for the regurgitation.
I don't understand.
No problem. So, when blood leaks back into the left ventricle, it fills up more than normal. To manage this extra volume, the ventricle enlarges or dilates, which helps it pump out more blood to keep up with the body's needs.
I don't understand.
Think of it like this. If more blood keeps coming back into the ventricle, it stretches to hold it all. This stretching, or dilation, helps the ventricle pump out more blood with each beat.
And how does it dilate?
The dilation happens because the ventricle's muscle fibers stretch to accommodate the extra blood. Over time, this stretching allows the ventricle to hold and pump more blood, but it can also weaken the heart muscle over time if it stretches too much.
Okay. Aortic regurgitation, heart sounds.
In aortic regurgitation, you typically hear an early diastolic murmur. It's a decrescendo sound right after the aortic valve closes due to blood leaking back into the ventricle.
Why is it during diastole? Because it's at that time where the leakage usually happen.
Exactly. During diastole, the heart relaxes and the aortic valve should be closed. If it doesn't
What
seal
does
properly,
uh, what does concomitant systolic murmur mean?
concomitant systolic murmur means a murmur that occurs at the same time as another event. In this case, during systole. It suggests there's an additional issue like aortic stenosis or another valve problem happening alongside the regurgitation.
Mm-hmm.
Right, so it means there's a systolic murmur happening at the same time,
What is
indicating
valve?
multiple.
What is prolapse?
Valve prolapse is when a valve's leaflets don't close properly and bulge backward. This can cause blood to leak backward, like in mitral valve prolapse, where the
So,
mitral valves.
so can we have prolapse in both mitral and aortic?
Yes, both mitral and aortic valves can have prolapse. Mitral valve prolapse is more common, but aortic valve prolapse can also happen,
Why is
usually due to
mitral prolapse more common?
mitral valve prolapse is more common because the mitral valve has a more complex structure and is under significant pressure. It's also affected by conditions like connective tissue disorders, which can cause the leaflets to become floppy.
S- So, chordal rupture, papillary muscle failure, is this only about mitral regurgitation, or can it occur with aortic too and also stenosis?
Chordal rupture and papillary muscle failure are most commonly associated with mitral regurgitation. However, they can indirectly affect the aortic valve if there's severe damage or complications,
Why
but they're
why though
not.
is only for mitral? Is it do the chordal tendinae and the papillary muscles connect only to the mitral valve?
Yes, exactly. The chordae tendineae and papillary muscles primarily support the mitral valve. They help anchor the valve leaflets, preventing them from prolapsing into the atrium. The aortic valve doesn't have these structures, which is why prolapse and issues
And
with the chordae tendineae.
why did God choose that the mitral regurgitation? Sorry, why did God chose to put chordal rupture and papillary muscles to the mitral valves? When I say God, I mean evolution and nature. I don't know. Dude.
Haha, I get you. Evolution shaped the mitral valve this way because it handles high pressures between the left atrium and ventricle.
But excuse me, sir. Our aortic valves handle high pressure, maybe even more high pressure.
True, the aortic valve does handle high pressure, but its structure is different. It relies on its cusps and the surrounding aortic root for support. The
Well,
mitral
what
valve's leaflet.
we don't have s- uh, what is the support that the aortic valves have that the mitral don't and
The aortic valve has three strong, thick cusps that open and close with each heartbeat. These cusps are supported by the aortic root and surrounding tissue, which help them withstand the pressure. Unlike the mitral valve, it doesn't need chordae tendineae or papillary muscles to function.
uh,
You're welcome.
mhm.
Anything else on your mind?
Um, yeah, so much, dude. Annular dilatation, why is it connected to mitral regurgitation and not aortic?
Annular dilatation is when the ring around the valve enlarges. It's often linked to mitral regurgitation because the mitral annulus can stretch due to conditions like left ventricular dilation. This stretch prevents the valve leaflets from closing properly, causing regurgitation. The aortic annulus doesn't typically dilate in the same way.
What is annular dilatation?
Annular dilatation is when the ring-shaped base of a heart valve stretches out. This can happen due to conditions like heart enlargement, making it harder for the valve leaflets to come together and close properly,
And does this
leading to
happen
issues.
for both semilunar and atrioventricular or only atrioventricular?
It primarily happens with atrioventricular valves like the mitral and tricuspid because their annulus is more flexible and can stretch.
Uh-huh.
The semilunar valves like the aortic and pulmonic have more rigid structures, so annular dilatation is less common.
So is it mainly mitral that's the problem? Tricuspid, we haven't heard a lot about tricuspid problems.
Mitral issues are more common and often more noticeable, but tricuspid problems do happen, especially in cases like tricuspid regurgitation.
And why are they more noticeable, the mitral than the tricuspid?
The mitral valve is under higher pressure since it's on the left side of the heart,
Hmm.
which pumps blood to the whole body.
Okay,
When
what
it
are the
drops,
parasternal lymph nodes function?
parasternal lymph nodes are part of the immune system. They help filter lymph fluid and can become enlarged if there's an infection or other issues in the chest, like cancer.
Yeah. Tell me again about the
Exactly.
parasternal lymph nodes function and the reason for their anatomical location too.
Sure. Parasternal lymph nodes filter lymph from the chest wall, breasts, and upper abdomen. They're located along the sternum, which makes them strategically placed to catch and filter any harmful substances.
What do they do?
They act as filters, catching bacteria, cancer cells, or other harmful particles in the lymph fluid.
Okay,
They
I
help.
want us to locate some things now. Azygos, hemiazygos, accessory hemiazygos. So let's put them in the location.
All right, the azygos vein runs along the right side of the vertebral column, draining into the superior vena cava. The hemiazygos vein is on the left, crossing over to join the azygos. The accessory hemiazygos is also on the left, but higher up, and it also connects to the azygos vein.
So does the accessory hemiazygos connect to the hemiazygos?
Yes, it does. The accessory hemiazygos typically joins the hemiazygos vein before they both cross to the right side to connect with the
And
azygos vein.
then where does the azygos go?
The azygos vein continues upward along the right side of the spine and then arches over the right lung's root to empty into the superior vena cava
Yeah, on the
and
other
then carries
side,
over.
does it go to the diaphragm?
Yes, it does. The azygos vein actually passes through the diaphragm via the aortic hiatus before it reaches the superior vena cava.
Yeah, but so the one end, things have two ends. One start, one end. So you say end is superior vena cava. What is start?
The azygos vein starts in the abdomen, around the lumbar region, where it forms from smaller veins, like the right ascending lumbar vein and subcostal veins. Then it ascends along the right side of the spine.
Mm-hmm.
Yup, so it runs from the lumbar region up to the superior vena cava.
Oh, brother, we're going to have trouble now. We're going to talk about development of the heart when we were kids, infants, or whatever fetuses.
No worries, the heart's development starts early in the embryo, forming from a simple tube that folds and partitions into chambers. By around 8 weeks, the heart structure is mostly complete, and it keeps growing and refining until birth.
Let me ask. So guys, I know I'm interrupting all the time. I'm thinking of changing the title to Live Medical or Live Medicine Studying with ChatGPT. I'm not sure if that's a more representative title of what we're doing here, because people might assume that me and ChatGPT are talking about. I don't know. I mean, to be fair, the title does say we're talking about like valves and mediastinum and stuff, but maybe they're expecting it to be more chatty, whereas I'm doing it in a more study focused manner, which is like, more rigid. And I don't know. I don't know. What do you think, ChatGPT? What's the best title? Title number one for our podcast. The Human Dash AI podcast. Um, and then topic X, for instance, mediastinum and valves. Or option number two, uh, study with me. That, and then I put a dash, and then I say, um, live with ChatGPT, and then topic X.
I like the idea of a study with me format, especially if you're focusing on structured educational content. It sets the expectation for a more in-depth study session. If you want a balance between chatty and educational, the Human AI podcast with a subtitle might capture both.
Yeah, the thing is, I started it as more chatty, but I don't have time, dude.
I get that. If time's tight, a study with me format could be efficient and still engaging. It sets a clear focus and expectation for listeners who are there to learn alongside you.
Yeah, but I like the idea of Trojan horse where listeners might come because sometimes listeners wouldn't come if it's a study with me video because they're like, "Ah, I hate studying because I hate school," and then you might get them into it if you call it a podcast and they view it as something more relaxing.
That's a clever approach. Using a podcast format with a casual title might draw in listeners who wouldn't typically go for study sessions. Then you can slip in the educational content in a more relaxed way.
But it might annoy people because at the end of the day, this is a very intense study podcast.
That's true. Balancing expectations is key. Maybe a blend of both. A title that's inviting but hints at the in-depth content so listeners know what to expect.
Maybe I can put one on the thumbnail and the other one on the title.
That's a great idea. A catchy title and a more descriptive subtitle or thumbnail could give a fuller picture. That way, you attract a broad audience, but still set clear expectations.
All right, let's talk about the development of the heart and the heart tube. So day 16 to 18, I don't know why so specifically, they have two heart tubes formed by the mesoderm in the cardiogenic area.
Exactly. Around days 16 to 18, the mesoderm forms two heart tubes in the cardiogenic area. These tubes eventually fuse to create a single primitive heart tube, which will later develop into the chambers of the heart.
Why? What is a mesoderm?
The mesoderm is one of the three primary germ layers in an embryo.
What is
It
the
forms
other?
structures like
Endoderm and ectoderm.
That's right. The other two germ layers are the endoderm, which forms the gut and internal organs, and the ectoderm, which develops into the skin and nervous system.
So then we have five regions developed within the fused heart tube, from inflow and caudally to outflow and cranially. I don't understand caudally and cranially. Please explain. And then it says it's the sinus venosus, primordial atrium, primordial ventricle, bulbus cordis, and truncus arteriosus.
Sure, caudally means toward the tail or lower end, while cranially means toward the head or upper end. In the fused heart tube, the sinus venosus is at the inflow caudal end, and the truncus arteriosus is at the outflow cranial end, with the primordial atrium, ventricle, and bulbus cordis in between.
And why are they in this? Give me the etymology of the five regions and explain to me why are they in this order.
The names reflect their positions and functions. Sinus venosus means a cavity that collects venous blood. Primordial atrium and ventricle are early forms of the heart's chambers. Bulbus cordis means bulb of the heart, a structure that contributes to the ventricles.
I feel like you haven't answered to me in an adequate fashion.
Got it. The order of these regions reflects the sequence of blood flow and development. Sinus venosus is where blood enters. The primordial atrium and ventricle are the early chambers. Bulbus cordis aids in pumping, and truncus arteriosus channels blood out. Each name is based on its position and role.
Hmm, interesting.
Glad you found it interesting.
What's the function of each one?
Sure, the sinus venosus collects blood from the body. The primordial atrium receives this blood. The primordial ventricle pumps it forward. The bolus cordis helps with ventricle formation and pumping. And the
Oh,
truncus arteriosus channels blood out to the aorta
okay,
and
now it
medullary
becomes
arteries.
too long and starts to fold, and then we have ventricles and outflow part, the bulbus cordis and the truncus arteriosus placed antero-inferiorly. Why specifically antero-inferiorly?
It's placed antero-inferiorly because as the heart tube folds, the ventricle and outflow regions shift forward and downward. This positioning allows them to properly align as the heart develops into its final shape, ensuring effective blood flow.
And then the atria and inflow region sinus venosus are eventually placed superior posteriorly.
Exactly. As the heart tube folds, the atrium and sinus venosus shift to a more superior and posterior position.
Why specific?
This
I don't understand why specifically these, you know?
It's due to the complex folding process. The heart tube bends and twists to ensure proper alignment of chambers and vessels, placing the atria above the ventricles for efficient blood flow.
Why not the other way around?
If it folded the other way, the blood flow wouldn't be as efficient. The atria need to be positioned above the ventricles to ensure blood moves smoothly from one chamber to the next.
Because of gravity?
Not gravity, but the way the heart's plumbing works. The atria need to fill the ventricles, so being above allows blood to flow downwards easily.
Because of
The
gravity.
folding it's more about efficiency.
Well,
The heart's
dude,
design
atria being above the ventricles, surely it means that it's smoother because of gravity.
gravity helps a bit, but the heart's pumping action is the main driver. The folding ensures chambers are aligned for
Well,
efficient
sorry,
pumping
sir,
and
but
blood flow.
the heart pumping action shouldn't care then about being below or above.
It's true the heart's pumping is strong, but the positioning ensures valves and chambers align for smooth, efficient blood flow.
Yeah, because gravity helps.
Yes, gravity does assist, but the main benefit is the alignment for efficient valve function and blood flow.
Yes,
The heart's
because
position.
gravity would help.
Exactly. Gravity does play a role, making it easier for blood to flow from the atria to the ventricles. It's a helpful factor in the heart's overall efficiency.
Excuse me, sir. So you're saying to me that the atria needs to be above the ventricles for smooth flow, but then I'm saying to you, yeah, because the pump is going to be helped by gravity, and you're saying, well, no, that's just a very small reason, and I don't understand why you say this. Then what's the big reasons?
I see what you mean. The main reason for the atria being above the ventricles is to ensure proper alignment for the heart's valves and chambers. This alignment allows efficient blood flow and prevents backflow, which is crucial for the heart's function.
All right,
Gravity helps, but
fair
it's
enough,
secondary
fair
to this.
enough. Okay.
Glad that makes sense.
And okay, so that explains superior and anterior, but why are they superior posteriorly, the atria and the influent region? Explain to me the posterior region.
The posterior positioning of the atria allows space for the ventricles in front. This setup helps the heart fit neatly in the chest and ensures efficient blood flow from the atria to the ventricles.
But yeah, but why don't we have the atria anterior?
Having the atria posterior leaves room for the ventricles to expand and contract efficiently. It also places the major vessels in the correct orientation for blood to exit the heart smoothly.
I don't understand.
No, no worries. The ventricles are the main pumping chambers, so they need more space. Placing the atria behind them allows the ventricles to expand properly and ensures the great vessels align correctly.
I do not understand why we want the atria posterior and not anterior.
Positioning the atria posteriorly gives the ventricles more room to pump blood forward. This arrangement also aligns the major vessels and valves for efficient blood flow.
Sir, you'd have to explain it in a different way because it's not going in.
Sure, think of it like this. The ventricles need to be in front for easy access to the outflow vessels. The atria are placed behind so they can feed blood into the ventricles without getting in the way of that outflow.
What is outflow?
Outflow refers to the blood leaving the heart through the major arteries, the aorta and pulmonary arteries. The ventricles pump blood into these vessels.
We have to go over septum primum develops with ostium primum inferiorly. What does this mean?
The septum primum is a thin wall that grows in the atrium, dividing it into left and right sides.
I don't understand this septum primum develops with ostium primum inferiorly. Etymology of septum, of primum, and of ostium.
Sure, let's break it down. Septum primum is Latin for first septum, referring to the initial partition that forms in the heart during embryonic development. Ostium means opening. The ostium primum is the first opening between the atria that allows blood flow before it eventually closes. So, septum primum develops with ostium primum basically means the first septum forms along with an opening that allows blood to pass through.
Okay, ostium is a passage then.
Exactly. The ostium allows blood to move between the atria in a developing heart. As development continues, new septa and openings form, eventually guiding blood flow into the right chambers.
So why does the ostium primum fuse and then an ostium secundum forms?
Great question. As the heart develops, the ostium primum eventually closes as the septum primum fuses with other heart structures. To maintain blood flow between the atria, another opening called the ostium secundum forms in the upper part of the septum primum.
I don't understand.
This ensures proper blood
Tell me
circulation
again, tell
during
me
fetal
again.
development. Sure, the ostium primum closes as the septum primum fuses with other parts of the heart. To keep blood flowing between the atria, a new opening called the ostium secundum forms in the upper part of the septum primum.
Why do they fuse in the first place though?
They fuse to create a solid wall between the atria. This helps separate oxygen-rich blood from oxygen-poor blood as the heart develops,
Okay.
ensuring
And then the septum secundum forms with the foramen ovale. What does this mean?
Exactly. The septum secundum forms next to the septum primum, leaving a small opening called the foramen ovale. This opening acts like a valve, allowing blood to bypass the lungs and flow between the atria before birth.
What is septum secundum?
The septum secundum is a second, thicker wall that forms to the right of the septum primum. It helps reinforce the division between the atria, and with the foramen ovale, it regulates blood flow during fetal development.
What is the foramen ovale?
The foramen ovale is a small opening between the septum primum and septum secundum. It allows blood to flow directly from the right atrium to the left atrium, bypassing the lungs while the fetus is in the womb.
So the foramen ovale is the new gap, but instead of what's the difference between foramen ovale and ostium secundum then?
The ostium secundum forms in the septum primum and is an initial opening. The foramen ovale
I
is the
thought
gap
I
between.
thought that the ostium primum formed in the septum primum.
You're right. The ostium primum is the first opening that forms in the septum primum. The ostium secundum develops later as the ostium primum closes. The foramen ovale forms between the septum primum and septum secundum.
Okay, so the ostium secundum is nearly identical to the ostium primum. It's on the same septum, but it's at a different point in time.
Exactly. The ostium secundum appears in the septum primum as the ostium primum closes. It's basically a second opening in the same septum, but at a different developmental stage.
All right. What does the ductus arteriosus do?
The ductus arteriosus is a blood vessel in a fetus that connects the pulmonary artery to the aorta. This allows blood to bypass the lungs since oxygen exchange happens through the placenta.
The
After birth,
pulmonary
it usually.
artery to the aorta.
Yes, exactly. The ductus arteriosus provides a shortcut for blood to flow directly from the pulmonary artery to the aorta, bypassing the lungs in fetal circulation.
Wow. And when
It's
does
pretty
it
fascinating.
stop?
The ductus arteriosus typically closes within the first few days after birth. The increased oxygen levels from breathing and changes in blood pressure signal it to close.
So the embryological remnant of ductus arteriosus is the ligamentum arteriosum. Is because like it looks like a ligament.
Exactly. Once the ductus arteriosus closes, it turns into a fibrous ligament-like structure called the ligamentum arteriosum. It no longer carries blood and just looks like a small ligament.
All right, let's talk about prenatal circulation. Umbilical vein carries oxygenated blood into the fetus from the mother. How come veins carry oxygenated blood?
Great observation. In prenatal circulation, the umbilical vein is unique because it carries oxygen-rich blood from the placenta to the fetus. Veins are defined by the direction they carry blood, not the oxygen content.
And
So,
oxygenated blood travels in the abdomen, inferior vena cava. This is like the opposite of what happens in adults.
exactly, it's a reversed pattern. In fetuses, oxygenated blood from the umbilical vein mixes with deoxygenated blood in the inferior vena cava. This mixed blood enters the right atrium, then follows specialized pathways to bypass the lungs.
So wait a sec, dude. I don't understand. Okay, why do we mix it? Okay, I understand the concept of reversing, but why is reversing needed?
The mixing is necessary because the fetus's lungs aren't functional yet. By mixing blood, the heart ensures some oxygenated blood reaches all parts of the body. The specialized fetal circulation pathways help direct the most oxygen-rich blood
And why is it
to
not
the...
a problem at this point? Because in the future
It's
it's a big problem, right to left shunt.
exactly. In adults, a right-to-left shunt can cause serious issues. But in fetuses, the placenta handles oxygen exchange. So mixing blood is normal. After birth, when the lungs take over, the circulatory system adapts.
Why is it normal?
It's normal because the fetus relies on the placenta for oxygen. The unique circulatory setup ensures oxygen reaches vital organs. After birth, these pathways close as the baby starts breathing.
Just a sec, guys.
Yep, everything changes at birth when the baby takes its first breath.
All right, so
It's amazing how it all works, isn't it?
wait a sec. So okay, so okay, we have mixed blood. So um wait a sec. So the right ventricle goes to the pulmonary trunk.
Yes, exactly. From the right ventricle, blood is pumped into the pulmonary trunk.
On but
In fetal
in fetuses too sometimes. It's like a secondary pathway.
Right, some blood does enter the pulmonary arteries, but thanks to the ductus arteriosus, most of it bypasses the lungs and goes straight to the aorta.
Yeah. But also blood coming into the pulmonary trunk might follow other routes, such as the ductus arteriosus or pulmonary arteries. Can you talk to me about these two routes?
Sure, blood from the right ventricle can follow two main routes. It can go through the pulmonary arteries to the non-functional fetal lungs, or it can bypass the lungs via the ductus arteriosus, directing it into the aorta for systemic circulation.
Through the ductus arteriosus?
Exactly. The ductus arteriosus acts like a bridge, letting blood move from the pulmonary trunk directly into the aorta, bypassing the lungs.
All right, good. Back to
Glad that
valves.
helped.
Back to valves, dudes. Let's talk mitral regurgitation consequences.
Sure, mitral regurgitation happens when the mitral valve doesn't close properly, causing blood to flow backward into the left atrium during ventricular contraction. This can lead to symptoms like shortness of breath, fatigue, and eventually heart failure if left untreated.
All right, let's continue with mitral regurgitation heart sounds. So beforehand, we talked about the crescendo, decrescendo, and that was for aortic stenosis. We talk about aortic regurgitation too. What was the other one we talked about that had a uh, just let me remember. Early diastolic murmur is the aortic regurgitation. Could you remind me the early diastolic murmur and the concomitant systolic murmur?
Sure, aortic regurgitation typically has an early diastolic murmur, best heard at the left sternal border. It often has a blowing decrescendo quality. The systolic murmur that can accompany it is usually due to increased flow across the aortic valve, often heard as an ejection murmur.
What is this concomitant?
Concomitant means occurring together. So in this case, it's referring to the systolic murmur that happens alongside the diastolic murmur.
And when does it happen, this concomitant?
The concomitant systolic murmur in aortic regurgitation usually occurs during systole, when the heart is contracting. It's often heard as a soft ejection murmur at the base of the heart.
And why in mitral you have pansystolic murmur?
Exactly. In mitral regurgitation, you typically hear a pansystolic or holosystolic murmur. This means the murmur lasts throughout the entire systole, from S1 to S2, often heard best at the apex.
Why is it such long?
It's long because the mitral valve doesn't close properly, so blood leaks back into the left atrium throughout systole. This creates a continuous sound from the first heart sound to the second heart sound, S2.
Mhm.
Exactly. The constant backflow causes that prolonged murmur.
So mitral valve prolapse, we have mid-systolic click and late systolic murmur. What is all this?
In mitral valve prolapse, the mid-systolic click is from the mitral valve leaflets snapping into place. The late systolic murmur follows due to regurgitation.
What do you
The
mean
murmur in
click? What do you mean clicking to place?
the click in mitral valve prolapse happens when the valve leaflets abruptly tense up or snap back during systole. It's a distinct sound caused by the abnormal movement of the prolapsing valve.
I don't understand.
No worries. Essentially, the click is the sound made when the mitral valve's flaps suddenly move during the heart's contraction. It's a key feature of mitral valve prolapse.
And why do we have a late systolic murmur?
The late systolic murmur occurs after the click because the prolapsing valve allows blood to leak back into the atrium. This regurgitation creates the murmur. which becomes audible in the latter
But I
part of
thought
systole.
that the regurgitation will happen in diastole, not in systole.
Exactly. Regurgitation in mitral valve prolapse happens during systole, which is why the murmur
No,
is
no,
late
I said the
systolic.
opposite. I said that I thought it was going to happen during diastole.
Ah, I see. Mitral regurgitation specifically happens during systole, when the heart contracts. Diastolic murmurs are usually linked to issues like aortic or pulmonic regurgitation.
I thought, but before we gave an example about, I think, aortic regurgitation, and it happened during diastole.
You're correct. Aortic regurgitation does cause a diastolic murmur. It's all about when the backflow happens. Mitral regurgitation, though, is during systole.
Why this difference?
The difference is due to the valve involved and the timing of the backflow. In aortic regurgitation, blood leaks back into the left ventricle during diastole.
Well, tell me
In
more,
mitral
dude.
regurgitation,
Why are you giving me so? Tell me more, Sabin, please.
sure. In aortic regurgitation, the aortic valve doesn't close properly, so blood flows back into the left ventricle after the heart pumps, which is diastole. For mitral regurgitation, the mitral valve doesn't seal properly, causing backflow into the left atrium during systole.
Yeah, but I don't understand why it's during systole and not during diastole.
It depends on which valve and the Vart's cycle phase. The aortic valve controls flow from the left ventricle to the aorta, so backflow occurs during diastole. The mitral valve is between the left atrium and ventricle, so its regurgitation happens during systole.
But why? Why during systole? So surely it's very difficult for it to happen during systole because it's going on the other direction.
I see what you mean. During systole, the left ventricle contracts, pushing blood out. If the mitral valve doesn't close properly, that pressure forces some blood back into the
Ah,
atrium.
yeah, yeah, I forgot this. Wait, yes. So basically, during systole, yeah, the systole, yeah. The atria are in diastole.
Exactly. While the ventricles contract during systole, the atria are relaxed.
All right. I still don't understand why mitral stenosis is almost due to rheumatic fever.
Mitral stenosis is often due to rheumatic fever because the inflammation from rheumatic fever can damage the mitral
Wait,
valve.
sorry guys, I fixed the voice a bit.
Hey, rheumatic fever is a common cause of mitral stenosis, especially in places where rheumatic fever is more prevalent. The inflammation from rheumatic fever can cause scarring of the mitral valve, which leads to narrowing or stenosis over time.
But
It's not
why not try cuspid stenosis or why not aortic?
right. Other valves can also be affected by rheumatic fever. For example, aortic stenosis can happen, but the mitral valve is more commonly involved due to its structure and the way it handles blood flow. Cuspid stenosis or aortic stenosis can occur, but less frequently as a primary result of rheumatic fever.
But why specifically? I don't understand why specifically.
So the mitral valve is affected more often because of how rheumatic fever causes inflammation. The mitral valve's location between the left atrium and ventricle means it's exposed to higher pressure changes. This makes it more vulnerable to scarring from repeated inflammation episodes. That's why mitral stenosis is more common.
Okay, again, please.
The mitral valve is often affected because it sits between the left atrium and ventricle, where pressure changes are high. This makes it more prone to scarring from inflammation, which is why rheumatic fever often leads to mitral stenosis.
Why is pressure changed from the ventricle to the vessels that take it to the body not high?
The pressure changes are high in the left ventricle too, but the mitral valve is more susceptible because of its structure and function. It's thinner and experience this narrowing
Okay, yeah,
causes
sorry, I don't understand why though the rheumatic fever is specifically mitral. I mean, we have pressure differences in all the valves.
That's true. All valves experience pressure differences. The mitral valve is particularly vulnerable because of its position and structure.
Well,
The left
what
side
does
of the
its
heart,
position and structure have that the others don't?
the mitral valve, sits between the left atrium and ventricle, handling high blood volume and pressure.
So
It's
what?
also
So what? We don't have high pressure and volume in the left ventricle in the aorta?
we do, but the aortic valve structure is more robust. The mitral valve's thin leaflets are more prone to scarring from inflammation, making it more
Well,
susceptible to
why
rheumatic
did
damage.
nature and evolution and God do it this way?
Evolution isn't always perfect. It often results in trade-offs. The mitral valve's design works well for most, but its delicacy makes it more vulnerable.
Well, why is it specifically rheumatic and not infective that targets the mitral?
Rheumatic fever is an autoimmune response triggered by a streptococcal infection. The immune system mistakenly attacks the heart, especially the mitral valve. It's not the infection itself, but the immune response that targets it.
Yeah, dude, and I'm telling you, why is rheumatic the one that attacks that attacks more, and it's not what's it called? Um, infective that attacks it more.
Infective causes like endocarditis can affect any valve, but rheumatic fever more commonly targets the mitral valve due to how the immune system reacts. It's just the way the body misdirects its response after a strep infection.
Yeah, so why is infective for all on all valves and rheumatic only in the mitral, dude? You're not answering to me. Answer to me, even if it takes an hour.
I understand. Rheumatic fever's immune response often targets the mitral valve due to its specific structure and blood flow dynamics. In contrast, infective endocarditis can involve any valve because it's a direct infection. The immune system's misfire in rheumatic fever makes the mitral valve more susceptible.
Uh, why?
The mitral valve's position and structure make it more prone to damage from the inflammation caused by rheumatic fever. The immune system's response targets heart tissue and the mitral valve
Well,
due to
why are the mitral valves as safe as the other valves when it comes to infective problems?
the mitral valve isn't necessarily safer from infective issues, but infective endocarditis can affect any valve. The difference with rheumatic fever is how the immune system specifically damages the mitral valve. For infections,
All right,
all
let's
valves
talk
harm.
about stridor and dysphagia and why they're mitral stenosis symptoms.
Sure, stridor is a high-pitched sound from upper airway obstruction, while dysphagia is difficulty swallowing. In mitral stenosis, the enlarged left atrium can press on nearby structures like the esophagus or airways, causing these symptoms.
All right, and what is BAV and TAVI? Do they have to do with percutaneous?
BAV, bicuspid aortic valve, and TAVI, transcatheter aortic valve implantation, are related. BAV is a congenital condition where the aortic valve has two leaflets instead of three, and TAVI is a minimally invasive procedure to replace a diseased aortic valve, often used in BAV patients.
And then we have, okay, what's auscultation? Is it when we're listening for murmurs?
Yes, auscultation is when we listen to heart sounds with a stethoscope. Murmurs are those extra sounds that can indicate valve issues like mitral stenosis.
Okay.
Exactly. Hearing a murmur can help diagnose issues.
And what's transcatheter valve replacement?
Transcatheter valve replacement, like TAVI, is a minimally invasive procedure where a new valve is inserted via a catheter, typically through the femoral artery, to replace a damaged valve without open heart surgery.
Doesn't sound very minimal invasive.
It might not sound like it, but compared to open heart surgery, it's a smaller incision,
All right,
shorter
guys.
recovery.
Sorry for interrupting ChatGPT all the fucking time. Yeah, we finished this. I'll see you tonight. And I'm tired. Love you.